चेक 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 हेलो 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 आवाज तो जा रही है। हेलो चेक 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 हेलो हेलो चेक हेलो चेक अब सही है गाना। हेलो लाइव बंद हो गया वही चल रहा है ये। चेक 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 हेलो हेलो चेक 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 हेलो 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 चेक चेक वन चेक चेक चेक
has evolved into a comprehensive multi-specialty institution addressing a broad spectrum of healthcare needs with excellence. The hospital has distinguished itself not only through exceptional patient care but also by setting pioneering standards in the medical field. Eternal Hospital holds numerous prestigious milestones. Further strengthening its leadership, Eternal Hospital pioneered Impella, TMBR and TABR procedures in Rajasthan and now leads the state as the first private institution to offer advanced Da Vinci Xi robotic surgery. Eternal Hospital Jaipur, a 250 plus bedded multi-specialty hospital founded in 2013, is the realization of a visionary dream by globally renowned cardiologist Dr. Samin K. Sharma and Mrs. Manju Sharma. Inspired by Mount Sinai's world-class medical model, their mission was to bring international standard healthcare to their hometown Jaipur. Combining excellence with affordability. Originally established as a specialized cardiac care center, Eternal Hospital has evolved into a comprehensive multi-specialty institution addressing a broad spectrum of healthcare needs with excellence. The hospital has distinguished itself not only through exceptional patient care but also by setting pioneering standards in the medical field. Eternal Hospital holds numerous prestigious milestones. Rajasthan, and now leads the state as the first private institution to offer advanced Da Vinci Xi robotic surgery. Eternal Hospital Jaipur, a 250-plus bedded multi-specialty hospital founded in 2013, is the realization of a visionary dream by globally renowned cardiologist Dr. Samin K. Sharma and Mrs. Manju Sharma. Inspired by Mount Sinai's world-class medical model, their mission was to bring international standard healthcare to their hometown Jaipur. Combining excellence with affordability. Originally established as a specialized cardiac care center, Eternal Hospital has evolved into a comprehensive multi-specialty institution addressing a broad spectrum of healthcare needs with excellence. The hospital has distinguished itself not only through exceptional patient care but also by setting pioneering standards in the medical field. Eternal Hospital holds numerous prestigious milestones. Further strengthening its leadership, Eternal Hospital pioneered Impella, TMVR and TAVR procedures in Rajasthan and now leads the state as the first private institution to offer advanced Da Vinci Xi robotic surgery. Eternal Hospital Jaipur, a 250-plus bedded multi-specialty hospital founded in 2013, is the realization of a visionary dream by globally renowned cardiologist Dr. Samin K. Sharma and Mrs. Manju Sharma. Inspired by Mount Sinai's world-class medical model, their mission was to bring international standard healthcare to their hometown, combining excellence with affordability. Originally established as a special healthcare needs with excellence. The hospital has distinguished itself not only through exceptional patient care but also by setting pioneering standards in the medical field. Eternal Hospital holds numerous prestigious milestones. Further strengthening its leadership, Eternal Hospital pioneered Impella, TMVR and TAVR procedures in Rajasthan and now leads the state as the first private institution to offer advanced Da Vinci Xi robotic surgery. Eternal Hospital Jaipur, a 250-plus bedded multi-specialty hospital founded in 2013, is the realization of a visionary dream by globally renowned cardiologist Dr. Samin K. Sharma and Mrs. Manju Sharma. Inspired by Mount Sinai's world-class medical model, their mission was to bring international standard healthcare to their hometown Jaipur. Combining excellence with affordability. Originally established as a specialized cardiac care center, Eternal Hospital has evolved into a comprehensive multi-specialty institution addressing a broad spectrum of healthcare needs with excellence. The hospital has distinguished itself not only through exceptional patient care but also by setting pioneering standards in the medical field. Eternal Hospital holds numerous prestigious milestones. Further strengthening its leadership, Eternal Hospital pioneered Impella, TMVR and TAVR procedures in Rajasthan and now leads the state as the first private institution to offer advanced Da Vinci Xi robotic surgery. Eternal Hospital Jaipur, a 250-plus bedded multi-specialty hospital founded in 2013, is the realization of a visionary dream by globally renowned cardiologist Dr. Samin K. Sharma and Mrs. Manju Sharma. Inspired by Mount Sinai's world-class medical model, their mission was to bring international standard healthcare to their hometown Jaipur. Combining excellence with affordability. Originally established as a specialized cardiac care center, Eternal Hospital has evolved into a comprehensive multi-specialty institution addressing a broad spectrum of healthcare needs with excellence. The hospital has distinguished itself not only through exceptional patient care but also by setting pioneering standards in the medical field. Eternal Hospital holds numerous prestigious milestones. Further strengthening its leadership, Eternal Hospital pioneered Impella, TMVR and TAVR procedures in Rajasthan and now leads the state as the first private institution to offer advanced Da Vinci Xi robotic surgery. Eternal Hospital Jaipur, a 250-plus bedded multi-specialty hospital founded in 2013, is the realization of a visionary dream by globally renowned cardiologist Dr. Samin K. Sharma and Mrs. Manju Sharma. Inspired by Mount Sinai's world-class medical model, their mission was to bring international standard healthcare to their hometown Jaipur, combining excellence with affordability. Originally established as a specialized cardiac care center, Eternal Hospital has evolved into a comprehensive multi-specialty institution addressing a broad spectrum of healthcare needs with excellence. The hospital has distinguished itself not only through exceptional patient care but also by setting pioneering standards in the medical field. Eternal Hospital holds numerous prestigious milestones. Further strengthening its leadership, Eternal Hospital pioneered Impella, TMVR and TAVR procedures in Rajasthan and now leads the state as the first private institution to offer advanced Da Vinci Xi robotic surgery. Eternal Hospital Eternal Hospital Jaipur, a 250-plus bedded multi-specialty hospital founded in 2013, is the realization of a visionary dream by globally renowned cardiologist Dr. Samin K. Sharma and Mrs. Manju Sharma.
The DES is better, so these are the guidelines. They're both drug-coated balloon and DES. DES is recommended, but DES is low. I would say has an edge over the drug-coated balloons, but we still use quite a bit of DCB in ISR of the DES. So now this was the patient with ISR. Now, what about the native vessel? This is a trial from China called REC phase 2-1 and basically show DCB in the blue and red in the regular DES group, compare DCB versus DES, which is what we use another stent, and basically shows that in native vessel, while we had a very effective in the instant restenosis, but the native vessel, drug-coated balloon was not good. You can even say that it was bad. Many of these, there is almost a trend towards higher mortality. But what they show also within there, that if you're a small vessel, both DCB and DES are okay. But if you're a large vessel, event rate is 2.5 and 3 times higher with the DCB. So clearly the large vessel, no good for DCB. The small vessels are okay for DES if you need to use it. And then the branch, where many trials have been done, that's for the side branch, do you just do a balloon or you do a DCB? And actually this data has shown that DCB has a lower event rate, lower subsequent outcome. So therefore branch point, the small vessel and ISR are the ones. So how do we take care of the coronary disease right now? The whole full circle going back to the balloon angioplasty era, that we dilate the lesion first and then we optimize, open it, plaque modification we call, by atherectomy.
Eternal Hospital Jaipur, a 250-plus bedded multi-specialty hospital founded in 2013, is the realization of a visionary dream by globally renowned cardiologist Dr. Samin K. Sharma and Mrs. Manju Sharma. Inspired by Mount Sinai's world-class medical model, their mission was to bring international standard healthcare to their hometown Jaipur. Combining excellence Care Center, Eternal Hospital has evolved into a comprehensive multi-specialty institution addressing a broad spectrum of healthcare needs with excellence. The hospital has distinguished itself not only through exceptional patient care but also by setting pioneering standards in the medical field. Eternal Hospital holds numerous prestigious milestones. Further strengthening its leadership, Eternal Hospital pioneered Impella, TMVR and TAVR procedures in Rajasthan and now leads the state as first private institution to offer advanced the
हमें की आवाज आ रही है।
चेक 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 किसको हेलो 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 अभी जो लीड लगाई उसी पे चेक करो ना। यही सारी बात ना। हाँ हेलो लो चेक करो फटाफट उस तरह आगे बैठे जोड़ लो नहीं आएगी वो मान लो वो एचडीएमआई में दिक्कत हुई तो एचडीएमआई के तो कोई बात नहीं। धीरे धीरे सुरेश सुरेश धीरे व्हाट्सएप पे बात किया ना। चेक 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 आ रहा है सही आ रहा है। हेलो हेलो हाँ तो दूसरी केबल जोड़ लो ना एक और लिया। हेलो दीपक जी आवाज आ रही है बढ़िया आ रही है एक बार गर्दन हिला दो। रुक जाओ एक क्या हो गया कहाँ चला गया और क्या चला गया फ्रीज कर रखा है क्या कर दिया मैं तो हेलो अरे अच्छा डायरेक्ट खोल लो ना। तो वहां से कम कर लो ना थोड़ा मैंने बिल्कुल डाउन कर दिया। हाँ वो तो क्यों और मिनिमाइज करते हैं क्यों वो के लिए हाई के लिए कर देगा मिनिमाइज। इस पे नीचे डालो ना ऊपर क्यों डालो अपने को वो करना है कि साइड में लाइव चलाना है साइड में लाइव का लाइव और सीवी ये रहेगी ये तो इधर क्या चाहिए नहीं सीवी वो भी बन कितने बोलो हाँ पहले डिफाइन करो ना गेस्ट छोड़ो उठा के लाने सारी स्लाइड है ओके बाकी की नहीं होगी ना अगर होगी तो फिर दिक्कत हो जाएगी टाइम में कैसे समझो आप वही एक कैमरा एक सीवी और बाकी के पीछे हाँ भैया लेके प्लीज कर दो फिर एक फिर विंडो वही करा otro por eso la voy a leer yo la voy a leer गया मैं दूसरा उसको बना रहा हूँ बड़ा होने के डॉक्टर देख लिया देख मेरी बात एक मिनट एक बार हम फिर वो हम लोग तो रीच कर दो वहाँ से ये वाले तो दोनों इसको छोटा ही कर दिया देखो एक बार पहले इसको छोटा बड़ा करो प्लीज हुआ इनपुट से कंपोजिशन सेलेक्टेड है नहीं मुझे लगा शेयर स्लाइस 3 है तो फिर वो बस कंपोजिशन एक ही बना देते हैं बड़ा मगर तो या बोले तो वो सब अभी भी टाइम लगा तो प्रेशर में कम काम हो अभी बना के नहीं अब रुको ना तो उधर ले लो। अच्छा उन दो को इधर ले आओ। और इसमें नीचे से गणेश चंद्र हटाओ। ये भी चार को चले। ये लाइव और पीपीटी पे डालो। ऑडियो खोल दो।
Eternal
इसमें क्यों नहीं आ रही है?
Eternal Hospital Jaipur,
अरे ये क्यों नहीं
a 250 plus bedded multi-specialty hospital founded
वीडियो? हाँ आएगा ना। कैप्चर करा दिया था। इसमें क्यों नहीं आ रहा?
Eternal Hospital Jaipur, a 250 plus bedded multi-specialty hospital founded in 2013, is the realization of a visionary dream by globally renowned cardiologist Dr. Samin K. Sharma and Mrs. Manju Sharma. Inspired by Mount Sinai's world-class medical model, their mission was to bring international standard healthcare to their hometown Jaipur, combining excellence with affordability.
आगे आगे।
Originally established as a specialized cardiac care center, Eternal Hospital has evolved into a comprehensive multi-specialty institution addressing a broad spectrum of healthcare needs with excellence. The hospital has distinguished itself not only through exceptional patient care but also by setting pioneering standards in the medical field. Eternal Hospital holds numerous prestigious milestones. Further strengthening its leadership, Eternal Hospital pioneered Impella, TMVR and TAVR procedures in Rajasthan and now leads the state as the first private institution to offer advanced Da Vinci Xi robotic surgery. Eternal Hospital Jaipur, a 250 plus bedded multi-specialty hospital founded in 2013, is the realization of a visionary dream by globally renowned cardiologist Dr. Samin K. Sharma and Mrs. Manju Sharma. Inspired by Mount Sinai's world-class medical model, their mission was to bring international standard healthcare to their hometown Jaipur, combining excellence with affordability. Originally established as a specialized cardiac care center, Eternal Hospital has evolved into a comprehensive multi-specialty institution addressing a broad spectrum of healthcare needs with excellence. The hospital has distinguished itself not only through exceptional patient care but also by setting pioneering standards in the medical field. Prestigious milestones. Further strengthening its leadership, Eternal Hospital pioneered Impella, TMVR and TAVR procedures in Rajasthan and now leads the state as the first private institution to offer advanced Da Vinci Xi robotic surgery. Eternal Hospital Jaipur, a 250-plus bedded multi-specialty hospital founded in 2013, is the realization of a visionary dream by globally renowned cardiologist Dr. Samin K. Sharma and Mrs. Manju Sharma. Inspired by Mount Sinai's world-class medical model, their mission was to bring international standard healthcare to their hometown Jaipur. Combining excellence with affordability. Originally established as a specialized cardiac care center, Eternal Hospital has evolved into a comprehensive multi-specialty institution addressing a broad spectrum of healthcare needs with excellence. The hospital has distinguished itself not only through exceptional patient care but also by setting pioneering standards in the medical field. Eternal Hospital holds numerous prestigious milestones. Further strengthening its leadership, Eternal Hospital pioneered Impella, TMVR and TAVR procedures in Rajasthan and now leads the state as the first private institution to offer advanced Da Vinci Xi robotic surgery. Eternal Hospital Jaipur, a 250-plus bedded multi-specialty hospital founded in 2013, is the realization of a visionary dream by globally renowned cardiologist Dr. Samin K. Sharma and Mrs. Manju Sharma. Inspired by Mount Sinai's world-class medical model, their mission was to bring international standard healthcare to their hometown Jaipur. Combining excellence with affordability. Originally established as a specialized cardiac care center, Eternal Hospital has evolved into a comprehensive multi-specialty institution addressing a broad spectrum of healthcare needs with excellence. The hospital has distinguished itself not only through exceptional patient care but also by setting pioneering standards in the medical field. Eternal Hospital holds numerous prestigious milestones. Further strengthening its leadership, Eternal Hospital pioneered Impella, TMVR and TAVR procedures in Rajasthan and now leads the state as the first private institution to offer advanced Da Vinci Xi robotic surgery. Eternal Hospital Jaipur, a 250-plus bedded multi-specialty hospital founded in 2013, is the realization of a visionary dream by globally renowned cardiologist Dr. Samin K. Sharma and Mrs. Manju Sharma. Inspired by Mount Sinai's world-class medical model, their mission was to bring international standard healthcare to their hometown Jaipur. Combining excellence with affordability. Originally established as a specialized cardiac care center, Eternal Hospital has evolved into a comprehensive multi-specialty institution addressing a broad spectrum of healthcare needs with excellence. The hospital has distinguished itself not only through exceptional patient care but also by setting pioneering standards in the medical field. Eternal Hospital holds numerous prestigious milestones. Further strengthening its leadership, Eternal Hospital pioneered Impella, TMVR and TAVR procedures in Rajasthan and now leads the state as the first private institution to offer advanced Da Vinci Xi robotic surgery. Eternal Hospital Jaipur, a 250-plus bedded multi-specialty hospital founded in 2013, is the realization of a visionary dream by globally renowned cardiologist Dr. Samin K. Sharma and Mrs. Manju Sharma. Inspired by Mount Sinai's world-class medical model, their mission was to bring international standard healthcare to their hometown Jaipur. Combining excellence with affordability. Originally established as a specialized cardiac care center, Eternal Hospital has evolved into a comprehensive multi-specialty institution addressing a broad spectrum of healthcare needs with excellence. The hospital has distinguished itself.
Namaste, good evening esteemed doctors. Welcome to New Horizon in Cardiology, an evening where innovations meets intention, where experience meets evidence, and where every discussion ultimately circles back to one thing: saving lives better. On behalf of Eternal Hospital Jaipur, in association with RSSDI and Heart and Valve Foundation, I welcome each one of you. We are honored to have us wonderful gathering of physicians, endocrinologists and healthcare professionals who are committed to stay at the forefront of innovation and evidence-based medicine and improving patient outcomes. We also extend our gratitude to all our speakers who will be sharing their valuable insights throughout the evening. So, before going to enrich ourselves with New Horizon in Cardiology, may I request our distinguished guests, key position holders of RSSDI, to please come up on the stage for the lamp lighting. May I request Dr. Pradyuman Sharma sir to please come up for the lamp lighting.
What a great evening. I'm so pleased to see you, lovely faces, my seniors, my juniors, young dynamic. And आप जानते हैं कोई भी साइंटिफिक प्रोग्राम शुरू होने से पहले एक लैंप लाइटिंग होती है. आई विल बी कटिंग माई सेल्फ शॉर्ट सो दैट अपन लैंप लाइटिंग के लिए मैं कहता हूँ थोड़ा सा वो चला दें. एंड आई रिक्वेस्ट ऑल माई सीनियर पीपल, डॉक्टर नवल सर, अशोक गोयल, पोदार, मैडम कालिया, बॉस डॉक्टर डोगरा, प्लीज कम अप ओवर हियर फॉर द लैंप लाइटिंग. Lovedeep, we love to have your face also. Dr. Alok Mathura, boss, Dr. Alok. We'll also love to have Dr. Ishu Goel. She is a neurophysician from Fortis Hospital, a senior neurophysician. And Dr. At the same time, I request my honored speakers, Dr. Vivek Mathur, Dr. Prashant Dwivedi, Dr. Prem Ratan Degawat, kindly join us here.
सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा गणपतिये नमो नमः श्री सिद्धिविनायक नमो नमः अष्टविनायक नमो नमः गणपति बप्पा मोरया मंगलमूर्ति मोरया ओम गणपतिये नमो नमः श्री सिद्धिविनायक नमो नमः अष्टविनायक नमो नमः गणपति बप्पा मोरया गणपतिये नमो नमः श्री सिद्धिविनायक नमो नमः अष्टविनायक नमो नमः गणपति बप्पा मोरया मंगलमूर्ति मोरया ओम गंगा
Now, it's my honor to invite Dr. Pradyuman Sharma, for last 44 years consultant in diabetes, allergy, asthma and specialist in immunovaccine. He has been awarded National Lifetime Achievement Award and many more national and state awards. He has more than 14 fellowships in his own and he has written chapters in many medicine updates. So please welcome Dr. Pradyuman Sharma.
Honored to be over here. Thank you, madam. So as you all know, that the prevention is better than the disease, and prevention carries a lot of meaning. Way back down, almost 1970, we had a statins, and then statins has almost prevented 33% of the coronary attacks, cerebrovascular attacks, and high incidence of mortality, almost said to be more than 10,000 of the disease every yearly. Then came PCKS4 line inhibitors. They have done a very miraculous job to be given almost monthly doses, but now we have a time of siRNA. The real challenges, real solutions with Inclisiran, Lacvio, as we were on. It was 2001, and it has still now saved 30,000 lives in UK only. In one country, the data available that it has prevented death, 30,000 deaths. So now let's have what is new in prevention of a heart disease or coronary attack. And for this, we have a Dr. Vivek Mathur. Madam Dr. Vivek Mathur. I invite Dr. Vivek Mathur. He is a very wonderful, dynamic guy, and will be giving.
Dr. Vivek Mathur का जो topic है ना, वो real challenge है.
मेरे को इन्होंने मैडम ने change करा. हाँ, यही है ना. So इनका intro. But I believe, who doesn't know him, Dr. Vivek Mathur. V stands for Vivek and V stands for victory. Dr. Vivek Mathur, kindly come over here, and for this we invite our chairpersons. Dr. C.L. Nawal, I request you, a senior HOD from SS Medical College, now Geetanjali HOD, medicine, wonderful, dynamic, always having a recent updates in medicine. Daily WhatsApp has been updated. And second, we have Dr. Ashok Goyal as a cardiologist, a very young, dynamic, and he has written books also on a non-invasive management and congestive refractory heart failures. And we invite then Dr. P.C. Raka, a very senior fellow physician and one of known to be a great for his clinical equipment, and Dr. Podar, Dr. Mahesh Podar. I request you, a very smiling personality, always एक फोन पे हमेशा आवाज आती है, एक फोन पे हमेशा आते हैं, very popular known. So I request you to chairpersons to kindly be and just introduce our speaker, Dr. Vivek Mathur. Dr. C.L. Naval, would you please introduce Dr. Vivek Mathur?
Hello. So good evening to everybody. Today's there's a good session with selected very good topics to be discussed by eminent speakers. The first speaker is Dr. Vivek Mathur, and he will speak on real challenges, real solution with Inclisiran. This is a very important drug. So I invite, without just wasting time, I invite Dr. Vivek Mathur to just come on the dais and speak.
So very good evening, ladies and gentlemen, and I welcome and pay my respect to the senior chairpersons, and it's a lovely evening. And so at the onset, let me thank the organizers for giving me this opportunity to talk about the recent science managing the lipid profiles of the patient and selecting what to do and in which scenario what to do. So in the next few minutes, I'm going to just talk about the science, how we are going to manage the lipid profile of our patients that we are seeing day and out. And we'll talk about different scenarios as an example, and know your views also, and about the questions in your mind and the discussion. No disclaimer as yet. So this is my agenda. And at the onset, we know that ASCVD, that is atherosclerotic burden, is very high all over the world. We have so many patients. The number one killer, the number one mortality is with the heart problems, the atherosclerotic problems, stroke, heart attacks, peripheral arterial disease, so many things, and diabetes adds to that, hypertension adds to that. So after experiencing a heart problem, we know that the patients whom we are treating in the next 100 days, one of them out of 10 will again develop a problem, and again a heart attack, a stroke, or any other problem. So 1 in 10 person is going to have recurrent problem. And once you are diagnosed with such a problem, there are a high likelihood that more than 10% chance that you will have a second event. So this is just an onset and the setting that we are treating high-risk patients. Any patient who has suffered a heart problem now becomes a very high-risk patient. So this is the setting that the patient is categorized now into high-risk patients. So once we are deciding the lipid profile of the patient, we have to categorize them whether this is a low-risk patient, high-risk patient, very high-risk patient, or extremely high-risk patient. So these are the patients that we are treating, and LDL-C again is a target. Why? Because it's a modifiable target. So you can change your LDL-C and bring out the changes, and this translates into clinical success again. Now, this problem is very huge. The best of the countries, best of the resources, we are still not able to bring down the LDL cholesterol to the desired and the optimum and the recommended levels. For example, if you are treating a patient who has just had an MI, what will be the lipid levels at the end of 1 month? So as a clinician, we know that we want to bring down the LDL cholesterol to less than 55. But are we able to achieve this? So best of the countries, you see that the patients, 80% of the patients, we are not able to achieve this target of getting the LDL-C levels below 70 or 55 or 40, whatever your patient is. So this is a highly unmet need of the patients, that we are still not able to control the LDL cholesterol with best, this thing. Now there could be two approaches to that. Having seen your patient not able to control the LDL cholesterol, you again going to increase the dose of the drug, or maybe you're going to add another drug. For example, you're giving statins, you will add ezetimibe, or you will use bempedoic acid or other therapies. So this is the scenario that we are having. So real world, we have aggressive management to follow, and we are not able to, maybe the physician's inertia, maybe the patient's problem, but still you're not able to control this thing. So we know that only 20% of the patient will be able to have their guidelines directed, control of the statin. And now the challenge is to strike early and hard, very hard. So it is important that we employ the therapies which are available to us and not waiting them, and go on a stepwise manner and get the desired change. So this is my submission. So real world challenges, I'm going to talk about few case scenarios. Now this is an XYZ person who's just a very young person, 39 years old, male, 26 BMI, that means slightly overweight. He's a very, workaholic type of person, working day and night. He's diagnosed with diabetes with 5 years, duration of the diabetes. He just had a non-ST elevation MI. He had an angioplasty done, and one of the artery was stented. Now, this is the real world patient that we are seeing. So this is classified as very high risk patient, not a low risk patient. So he's a high risk patient, and your duty is to bring down the LDL cholesterol to less than 55 milligrams in coming week. In the next 1 month, you should see his LDL getting down to less than 55. So now the medication that he is taking is 40 milligrams of atorvastatin, metformin, empagliflozin. His HbA1c is 6.2. Current LDL is 154. So whatever therapies you are going to so initial LDL cholesterol is, to start with, you should know how much percentage you're going to bring it down. For example, if you want to bring down by 50%, that means in the next visit, whatever therapy you're using, it will close to 75. So a high dose statin usually works in the range of 40 to 50%. Atorvastatin 80 milligram, rosuvastatin 40 milligram. But if you add a 10 milligram of ezetimibe, maybe 60% of your goal can be achieved with a high dose statin plus a statin therapy. Now this type of person really needs a robust lipid lowering therapy that does not increase LDL-C in the presence of diabetes. So this patient is a high risk person with diabetes also, and should also have a convenient plan. Convenient plan means that he is workaholic, he's working out, he has to take pills every day for diabetes, for lipids, so kind of therapeutic burden is there, a pill burden is also there. So you have to see how can you help this patient. So sometimes the patient become intolerant to therapies, so then you have to think of another therapies like PCSK9, bempedoic, ezetimibe, and all these things. And it is also has been recommended that you use these therapies early into the treatment course. So now this patient is given Inclisiran, how will it help? Now, giving Inclisiran, this is a slide, very interesting slide, that it tells that the patient who have diabetes or even normoglycemic patients, if you give Inclisiran at day 0 and the another dose comes at 90 days, that means the next injection that you give is at 3 months, 0, 3, then every 6 months you keep on giving. So this is the dosage schedule for this. For the initial, if you can see, the at 90 days, you're able to bring down the cholesterol levels, mean percentage by more than 50%. So this is one goal achieved, that you're able to get the 50% down. Now these are the days for the therapy. So if you continue to treat with Inclisiran, you are able to maintain that 50% drop all through the treatment part, this thing. And the longest study that has been done with Inclisiran is up to 7 years. So 7 years, consistent benefit can be achieved if you are giving twice yearly therapy with Inclisiran. So this is an important thing. This is as compared to Inclisiran. So one of the important that as a clinician, we want to bring down the cholesterol to the lowest possible level for that patient. So this is this thing. So approximate 51% with diabetes and pre-diabetes and normoglycemia. At day 510 days, you can keep the LDL cholesterol to a lower level. Now, what is the Inclisiran first strategy earlier in the treatment? Now, I talked about stepwise approach and Inclisiran first therapy. Now, once the patient comes and you start with Inclisiran first. For example, at the 30th day, you start with Inclisiran. Then you can see that again, it's a faster reduction, and even at 1 year, the 53% reduction can be achieved, and about 72% of the patient will have a LDL cholesterol less than 55. 72% of the patient as compared to usual therapy. Now, this is the usual therapy, that you don't give such a type of therapy and you continue to do the stepwise approach. Only 8.9% of the patient in the usual care usually attain the desired value of less than 55. So the science has been telling us that earlier strike hard and start early. So this is the Inclisiran first strategy. Now, how does this also help in this thing? Now, there is a therapeutic burden or physician inertias and all these things. Now, look at the adherence to the treatment. If you have to take only 2 injections in a year versus evolocumab, this is a monoclonal antibody marketed as Repatha, in which case you have to take in a year 26 injections to get the same result. And if we remove the cost factor, we have 365 pills to take over in a year. So interaction with the treatment is only 2 times for cholesterol control with Inclisiran, 26 times with the monoclonal antibody, and 365 interaction with the treatment frequency for the pill. So it is easier for the patients to adhere to the treatment. They don't, and this kind of patient may skip his pills, kabhi bhul jayega. Sometimes he will not turn up for your consultation. Sometimes he will not get his lipid profile checked. So if you have given the injections, and these are treatment administered usually by the clinicians, so the adherence to the treatment is guaranteed. So this is the important part that I want to convey. So Inclisiran is associated with lower administration frequency as compared to the other therapies and have a high potential to treatment adherence. Now this is a Orient 8 trial. What happens if the patient takes over an extended period of time? 47% reduction in LDL was being achieved at the end of study period. Now there are 3 populations: overall population, ASCVD population, and ASCD equivalent patients. So you can see that atherosclerotic ASCVD patients were able to get the targets, that is less than 100 in 92% of the patient will have less than 100 LDL. 79% of the patient, and 55, about 66% of the patients will be able to get a very low level of LDL cholesterol. Now, this is also true with the diabetic status of the patient. If the patient is diabetic, then also you are able to control able to achieve the guideline directed treatment. So 52% reduction in the LDL cell in the patients with diabetes or without diabetes, It's a convenient dosing regime for the patient, and most of your patient will have a desired result and with the recommended LDL levels. So we as clinicians are guided by evidences and recommendations. So now, second case scenario. This is again a lady who's slightly obese, 32 BMI, female, 52 years. Now this patient has got a chronic kidney disease and she has underwent CABG and also has the grafts placed on multi-vessel. That means LAD and RC were involved. She is on atorvastatin, ezetimibe, EGFR of 35 and current LDL-C is 120. Now these are again a real-world patient who has got a bypass, slightly obese lady with CKD. Now this is again a very high-risk patient. Very high-risk patient. Why? CKD and grafted patient. CAD already a known case of CAD patient. So these are very high-risk patient. What is your treatment goal for LDL? Less than 55. Now again such patient requires very robust lipid therapy for control of the lipid levels. So again you have to give effective and consistent therapy and which is effective in the renal impairment patients. Now this is the guidelines of the UK Kidney Association also, that you start with the patient to give secondary prevention. You start with the Inclisiran once they are not able to achieve the targets and use this up to the stage 3B. That very CKD patient can also use this Inclisiran to bring down the desired result. Now these are the patients who have recent MI, remote MI and no prior MI. Again, at 90 days, that means after the first dose, you can expect a LDL reduction of 50%, and this has been consistent for over the next 2-3 years if you are giving this. So Inclisiran provides effective and consistent LDL-C reduction irrespective of the MI status. Again, Orion 9 and 10 and 11 studies, they were able to achieve less than 70 milligrams, 52% of the patients sustained LDL-C reduction with low the variability is very less with such molecules. Now, what about the kidney patients? Again, the safety is very important of the patient. So, as far as the Inclisiran is, discussed, the Inclisiran has got a very low, any adverse effect profile with such a molecule. So, it is very effective and can be given to CKD patients because how does Inclisiran act? Inclisiran acts over liver and it acts to reduce or interfere with the PCSK9 protein. PCSK9 protein is inhibited, so you have more LDL receptors over liver. What does LDL-C receptor does? It helps in clearing out the LDL. So you have more LDL-C receptors over the liver to clear your LDL. So in the patients, in the renal impairment patients, you can expect up to 53% reduction of LDL, which is fast, which is consistent, and which is reliable. So these are the important. So this kind of patient who has ASCVD, prior MI, bypass, now you have to attain the LDL-C. So more than 50% LDL-C reduction, 49% reduction in renal patients, and also even in the moderate renal dysfunction, 53% LDL-C reduction has been shown. Now the last case scenario, a gentleman in the age of 60, 28, that means slightly overweight. He is hypertensive, but has got a history of angioplasty in the last 3 years. Now, this is what kind of patient he is. Is he a low-risk patient? No. Is he a high-risk patient? Yes. But what sort of, he's a very high-risk or extremely high-risk patient. Why do you call them extremely high-risk patient? Because just in the span of 3 years, he has sustained 2 episodes of acute coronary syndrome and both has resulted in an angioplasty. So these are the patients who are having recurrent coronary syndromes. So these are the high-risk patients, extremely high-risk patient. So what are the guidelines for extremely high-risk patient? When you are seeing such patient at the end of 1 month, how much LDL do you want to see in their lipid profile? Is it less than 100? No. Is it less than 70? No. Is it less than 55? No. You want to see their LDL to be very low. That means around 40. So after having treated for 1 month, you should have 40 LDL. So it is quite difficult to achieve sometimes. So these are the extremely high risk patients in which we have to get the LDL level to less than 40. So this again, this gentleman also needs a very robust lipid lowering therapy. And at the same time, elderly people on multiple therapies. So you have to have a drug, no drug-to-drug interaction, and it is safer for these people to be used for over a long period of time. Now, Inclisiran again has over the various study protocols has shown that there has not been very much drug-to-drug interactions. The drugs which are using cytochrome P450 enzyme in the liver. So no more interactions with that. And in combination with the statins, so once the patient in statins and ezetimibe, you can use Inclisiran, and has not been shown to show any other adverse effects. And you can also switch between therapies. For the example, your patient is on evolocumab, you can switch to Inclisiran and without any major side effects. So in that study, groups and protocols, there has not been any major treatment related adverse events or emergent adverse events in such patient. So long-term safety, it has been studied in over more than 12,000 patients, and exposure has been 7 years, and so long-term safety is being safe. So without the risk of drug interactions, proven efficacy, and up to 6 years data has been there. So all these patients, last 2 slides just. So we have just talked about 3 kind of patients. 2 of them were very high risk patient, and the last patient was extremely high risk patient. So these are your patients who requires robust lipid lowering therapy to the tune of LDL less than 55 or 40. Now this is just a slide to just let. So low risk patients are those lipid patients who have no risk factors. High risk patients are normal patients that we are seeing coming with hypertension or diabetes. These are your normal patients, and LDL you want to bring down to less than 100. Who are very high risk patients? ASCD patients, diabetes with prolonged duration, imaging, CT angio करा के आए सब blockage है 50-60 का. Heart failure patient, CKD patient, in which LDL less than 55, extremely high risk patient less than 40. These are the patients. So the various guidelines, 2025 guidelines, non-statin lipid lowering agent should be used, and maximally those people in which you have exhausted statins, and there are 2 things. One is time and one is the dose. So having tried your statin therapy for 3 months, आपने statins दे रखी हैं, आप ezetimibe भी दे रहे हो, bempedoic भी दे रहे हो, आपने 3 महीने हो गए, पेशेंट का LDL कंट्रोल नहीं आ रहा है, Inclisiran पे चले जाइए. So this is important that you have seen that, and dose of the therapy. अगर वो गया, and the other point is 1 month. 1 month target when you have given the therapy. 1 महीने के बाद उसकी lipid profile करा के देखिए how much it is, and for next 3 months you can see that. So these are the treatment options that we have for this. So to summarize my talk, so young patient who are very busy patients, important patients, diabetic patient, you can, and in which adherence to the therapy, therapeutic burden is there, you have to think of, early therapies, so you can use multi-vessel patients, CKD patients, again you have to effectively lower the LDL cholesterol in the presence of lower renal impairment, and those patients who have been having recurrent events, पहले CABG हो गई या PCI हो गई, PCI के बाद एक और PCI हो गई, Inclisiran can help, and it has got a long-term safety and drug-to-drug interaction. So my key messages are, LDL-C reduction is very important. It reduces the cardiovascular risk reduction is there. So there are greater benefits if you start early, and significant decrease in LDL-C. Combination lipid lowering therapy in high-risk patient, and avoid treatment delays, enabling large LDL-C reduction. So the idea is to get your LDL cholesterol very fast. In the next 1 month, you should be able to bring down the LDL cholesterol. So mostly 2 injections per year effectively reduces the LDL-C, well tolerated, good safety profile, and it can be tolerated over maximally tolerated statin therapy or monotherapy in these patients. So I thank you all for your kind listening, and thank you.
Hello. Thank you very much, Dr. Vivek Mathur, for the very lucid talk about the atherosclerotic disease and the role of anti-lipid drugs. My question is that in Orion trials, they kept all the patients in whom the LDL was more than 70. and the mean was 104. So, isn't it? And all the patients who achieved the target less than 65, they said that it's okay, it's a good drug. That's the one question. So the most of the patients were of very low LDL levels, and we achieved 65, less than 65 percent in most of the patients, and then they said that it's a good drug, that it is decreasing the cholesterol level less than 65. One thing. Second is that in our scenario, in Indian scenario, the triglyceride is also very important factor. So whether this drug is also decreasing the triglyceride or not.
So, thank you. So, Inclisiran does not act over the triglyceride. It's an LDL, it acts over the LDL receptors. And there has not been any conclusive proof that it affects the triglyceride metabolism and helps in triglycerides. Yes, Indian scenario, diabetic patients, the kind of diet that we have very high triglyceride levels. So Inclisiran does not help in that. And the important is to, the science has told us that importance is of reducing. First, your target is an LDL cholesterol, total cholesterol. HDL and triglyceride comes a little later. But whether they are not important, but they are important. Yes, they are important. But once you have controlled the LDL cholesterol, now we have classified patients into different group scenarios. So Inclisiran has been able to show that the level of cholesterol that you desire to control and get in the patients can be achieved with this. Now, whether you want a 70 or 55, how are you going to achieve, in what kind of patient that you want to achieve. So the trials have got, a distinct population of patients, different kind of patients that they have.
Precise, very short answers to address.
So I think
concluding answer, just take away message.
So takeaway message is that it has been able to control and give you a desired level, and most of your patients will have a LDL cholesterol less than 55. Most of your patients.
Truly said, the only preventive drug, before we had only one preventive drug, was the steroids. Then later on, it was in 2015, PCSK9 inhibitors did come, evolocumab. Now, this is a very potent Inclisiran, which has been last almost 5 years down in the market, but has showed a remarkable results. And the drug has proven to us more than the efficacy what was expected. This included the primary prevention, this included the secondary prevention. As what the lipid guidelines, this recently has been generally updated, that if you are very high, then it should 30, then it is 55 and 70. So truly said, thank you very much for excellent delivery of the session.
Thank you.
And for the next session, I request Dr. C.L. Double to kindly call upon Dr. Prem.
Thank you very much, team Eternal Hospitals Cardiology. Next speaker is Dr. Prashant Dwivedi. He will be speaking on DAPT, right therapy, right patients, and right durations. Dr. Prashant Dwivedi is a director in charge of TAVR and structural heart disease program cardiology, a senior consultant, and he is a highly qualified cardiologist from with the MBBS and MD Gold Medalist from the MGM Medical College Indore. He did his DM Cardiology Gold Medalist from the King George Medical College Lucknow. He further pursued advanced fellowship in interventional cardiology, structural heart disease from very reputed Mount Sinai hospitals, Newark, USA. He is among the few specialists in the country with extensively trained in the advanced structural heart intervention like TAVR, Mitra collapse, and TMVR. With experience of more than 650 with TAVR procedures, his expertise includes complex coronary angioplasty, valve replacements, and minimally invasive cardiac interventions. He is recognized for this proficiency in cutting-edge transcatheter and structural heart therapies. I call upon Dr. Prashant Dwivedi. Please welcome.
Good evening, everyone. First of all, thank you everyone for coming in this evening symposium. And I would like to thank Dr. Pradyuman and RSSDI for giving us this opportunity. So in next few minutes, I am going to talk about the antiplatelet, right therapy to right patient for the right time. So why antiplatelet therapy matters? It's we all know that the antithrombosis is platelet-driven process. And the key role of antiplatelet comes in picture in a patient who has acute coronary syndrome, patient who had a PCI, coronary intervention has been done, or in patients with secondary prevention. So we need to balance the ischemic risk as well as the bleeding risk. So the mechanism of platelet activation is, so what happens in coronary atherosclerosis is basically it's a plaque rupture and followed by the platelet adhesions. And then the platelet activation happens by thromboxy A2 pathway or the P2x12 pathway. So the aspirin predominantly goes through the thromboxane A2 pathway, and the clopidogrel, ticagrelor, and prasugrel goes through the P2x12 pathway. And the final common pathway is GP2B3A inhibitors. So there are multiple agents: aspirin, clopidogrel, prasugrel, ticagrelor, IV, cangrelor, and GP2B3A inhibitor. So aspirin is irreversible COX-1 inhibitor, P2x12 inhibitor are the clopidogrel, ticagrelor, prasugrel, and the IV agents are cangrelor and the GP2B3 inhibitors. If we look at the comparison of P2x12 inhibitors, and so if you look, the onset is the slowest in the clopidogrel while it is fastest in the ticagrelor. So the potency wise, the prasugrel and ticagrelor has high potency, and the ticagrelor is reversible while the clopidogrel and the prasugrel are the irreversible agent. And the key issue is ticagrelor has associated with dyspnea, while the prasugrel is associated with high bleeding risk, and the clopidogrel is associated with some genetic resistance which can lead to a variable response of the medicines. So the concept of right patient is, whenever we talk about the right patient, we need to assess what is the patient's age, what is the weight of the patient, is there any history of prior stroke, TIA, what is the renal function of the patient, and is there any bleeding risk, or how complex PCI we are doing. Because sometimes we are doing with a left main PCI, multiple stents, complex rotablation, impella assisted, multivessel PCI. In those situations, the ischemic risk is relatively high. So high ischemic risk occurs in a patient with acute coronary syndrome, diabetes patient, prior MI patient, and a complex PCI patient. So in these patients, prefer the potent P2x12 inhibitor, especially the ticagrelor or the prasugrel. Then what about the bleeding risk? So the patient who are elderly, age more than 75 years, or the patient with anemia, chronic kidney disease, prior bleeding episodes, or the patient who is already required anticoagulant or already on the anticoagulant, oral anticoagulant therapy, these patients are high bleeding risk. So in these patients, we should consider for the DAPT for the shorter duration, as well as the less potent clopidogrel P2x12 inhibitor has to be used. Then what about the acute coronary syndrome? So initial therapy in all acute coronary syndrome patients should receive aspirin irrespective of any situation. So the loading dose followed by the daily low dose has to be given. The DAPT is mandatory with aspirin and one of the P2x12 inhibitor. It could be clopidogrel, it could be ticagrelor or a prasugrel, depending on the risk of bleeding versus risk of ischemia. So prefer, especially in SCS patient, prefer the ticagrelor or the prasugrel, and then we need to strategize the depending on the STEMI or non-STEMI, because sometimes if the patient is coming with non-ST elevation MI, so this patient should go for angiography, and after angiography this patient can convert into coronary artery bypass graft surgery, or it can go into the angioplasty. So if a patient comes with a non-STEMI in emergency, don't give a prasugrel. You can give a clopidogrel, and then in the cath lab, if you think there is no need for prasugrel, or if there is need of prasugrel, then you can give a prasugrel. Because if we load with a prasugrel and patient comes in the cath lab, and if we have already loaded the prasugrel and now the patient is, we found that in the coronary angiography there is a triple vessel disease and patient need to go for CABG, then we have to wait for another 5 to 7 days to bring down the effect of prasugrel. So that's why don't give the prasugrel in emergency. It has to be given only in the cath lab when the patient comes to us with the acute coronary syndrome. So then what about the chronic coronary syndrome? So if there is stable coronary artery disease, we have to give the aspirin as a monotherapy. But if the same stable CAD patient undergoing for a coronary intervention, then DAPT is recommended for 6 months. Previously it was recommended for at least 12 months, but now the new recommendation is at least 6 months. It can be prolonged for the 12 months if the ischemic risk is high. Then what about the duration? So in all ACS patients, irrespective, 12 months of dual antiplatelet therapy is recommended. Stable CAD PCI, 6 months of therapy is recommended. If there is high bleeding risk, 1 to 3 months of DAPT is recommended. And if suppose we are giving a short DAPT duration for around 1 month or 3 months, and after 1 or 3 months, the newer recommendation is prefer ticagrelor instead of prasugrel as a single antiplatelet after 1 or 3 months. So if we need to give a extended duration, more than 12-month extended duration is also can be given if the ischemic risk is high, especially in a situation where the patient is diabetic, having a multivessel PCI, or there is a prior recurrent acute coronary syndrome. Then what about the de-escalation strategy? Sometimes patient develop dyspnea with the ticagrelor, or the different side effect with the prasugrel, or a bleeding risk is high, or some bleeding is happening. In those situations, we might need to de-escalate the strategy, and we need to switch from highly potent drug to lower potent drug. So from ticagrelor, prasugrel to clopidogrel. So a special situation, elderly, avoid prasugrel. In CKD patient, these patients are a high bleeding risk because they already have a platelet dysfunction. And if there is a need for oral anticoagulant therapy, try to give triple therapy as short as possible, because triple therapy increase the bleeding risk. So if the patient needs a long-term anticoagulation, or prefer dropping aspirin early and then continue the oral anticoagulant as well as the prasugrel, as well as the clopidogrel. So if patient needs a triple anticoagulant therapy, keep the patient on triple anticoagulant therapy, oral anticoagulant, aspirin and clopidogrel. Keep it for either 1 week to 1 month, and then stop aspirin, continue oral anticoagulant and continue clopidogrel for 6 months to 1 year. And after 1 year, only oral anticoagulant therapy is enough. So what about the post-transcatheter aortic valve replacement or post other transcatheter therapy? So DAPT is recommended for 3 to 6 months, and then a single antiplatelet therapy is recommended. But if the patient is having a high bleeding risk, especially if the patient is of 85 years, more than 90 years, 95 years of age, then the single antiplatelet therapy is enough. If already on anticoagulation, continue anticoagulant and no need of antiplatelet. If patient is undergoing transcatheter aortic valve replacement along with the coronary intervention, then DAPT for 1 year is recommended. And if already on anticoagulant and now TAVR plus PCI is being done, then give anticoagulant plus clopidogrel. Don't give a prasugrel with oral anticoagulant or a ticagrelor with oral anticoagulant, because then both of them can increase the risk of bleeding. So so a step-wise approach has to be, we always need to understand whether it's an ACS patient or a stable angina patient. Then we need to assess the ischemic risk versus the bleeding risk. Then we need to choose the drug, whether we need to start the clopidogrel, prasugrel or a ticagrelor along with aspirin. Then we have to decide the duration, and then we have to reassess periodically whether there is a patient is having a side effect, any bleeding risk, or the ischemic risk is now increasing. There are different trials has been done which has recommended the newer guideline. And so the take home message is, one size does not fit for all. We have to individualize the therapy, and we have to balance the ischemia and the bleeding, and then we have to reassess dynamically. So this is all the summary what we have discussed just now. So this is important, that right therapy to the right patient at the right time is the essence of precision cardiology. Thank you.
Thank you very much, Dr. Prashant Dwivedi, for the wonderful talk. Now I invite Dr. Pradhamar for the expert comments.
No, it never beat me. We have our Dr. R.S.K. there. Let's have an applause for him. He's one of the very great clinician, and he has all the queries for all the big dilemmas, but he has to leave a little early because he has some very dire emergency. So I invite you, sir, here to be as a co-chairperson over here. And now it's time to, just a small comment. You are such a pleasing personality, and let me tell you a story. In 1940, Dr. Lawrence Craven has given aspirin in chewing gum, and he has given to the 400 patients, and he documented that the aspirin has a proven role in CAD, but it was not being backed by any more the sciences. And now that it was in 85. 45 years down the line, aspirin got a FDA approval.
Exactly.
So beautifully answered and beautifully addressed. So I call upon the organizers to felicitate our chairperson.
Thank you very much, Doctor.
Yes,
it was very nice presentation, taking into the interest of physicians sitting in the hall. Because in most of the situations, the cases are referred to physician by dentist, ophthalmologist, gynecologist, what to do, how many days before extraction of teeth we have to stop aspirin or clopidogrel. Many a time chest physician also in the situation ki which drug is to be stopped, what to be continued, because in fibrocavitary disease and bronchiectasis many a times severe bleeding is there. So any amongst we physicians want to ask some question from Dr. Dwivedi. So really it is open, because this is one situation, you know, and very embarrassing situation for the physician. And one more important thing I want to make clear to the audience is that for what period, what shortest period or the longest period a physician can stop during the bleeding disorder happened with all these.
So Dr. Akai,
medicines.
we could get it. So the point, Dr. Prashant, we all want to be get ourselves aware for type of the surgery, small surgery, laparoscopic surgery, duration of the surgery, major surgery, minor surgery. Can you guys just take up the message to whom what to stop, not to stop, and post PDCI, how long we can not stop or we cannot stop, or what emergency? A little home message.
Yeah. So it's a very good question, sir. So what we need to understand is how much is the emergency. First of all, if the patient is having a stable disease in the teeth, he has to go for RCT. If it can be delayed, if suppose patient has already undergone a PCI, coronary angioplasty, because this is the most common situation where the patient already undergone coronary angioplasty and now patient is on double antiplatelet therapy, whether we can stop it or not. So if the patient needs a therapy which can be delayed up to 1 year, we should delay that therapy. Delayed therapy means if the RCT can be done after 1 year, delayed it. If hernia surgery can be done after 1 year, delayed it. Because the initial 1 year, the ischemic risk with the coronary angioplasty will be high if we stop the antiplatelet. So if the surgery is not an emergency, advised to do it after 1 year. If surgery is an acute, if it's an emergency and it's an acute life-threatening emergency, no matter what, you have to do the procedure. Because if suppose there is a acute intracranial hematoma and patient is unconscious, you have to do the surgery no matter what. You cannot wait for 3 days, 5 days to open it. So these are the two different spectrum. One is patient is stable, one is patient is totally unstable and hemodynamically unstable. Then third is patient has to go for a surgery, but not an acute life threatening, but it has to be done because it is affecting the patient's day-to-day life. In those situations, if we can consider for at least 6 months of DAPT and after that, that would be the first preference. If not, then what we can do is stop antiplatelet, start patient on heparin, enoxaparin for 3 days, 4 days, and stop antiplatelet for 5 days. So you stop the antiplatelet, start on heparin, and 24 hours before planned surgery, stop the heparin, enoxaparin, and get done the surgery, and then after 24 hours, restart the oral antiplatelet again. Yeah. So that you can so that you can balance both the ischemia part and you can balance the surgery also.
So and the first line is do it, and the next line is support the first line or talk in Dr. Prashant Dwivedi when you are in dilemma. Wonderful, a great session.
Thank you, sir. Thank you.
Let's all have
Thank you,
applause and let's all have an honor to our chairperson. And let's have a small memento and a group photo followed by it.
Thank you so much. So I would like to request Dr. Prashant Dwivedi and Dr. Prem Ratan Degawat, sir, to please come and do the honors.
So Dr. Prashant will be giving away the mementos to the chairpersons. Oh, what a roses and roses. ये बॉस रोजेस आपके लिए हैं, अब आप वहाँ पे इमरजेंसी अटेंड करने जा रहे हो ना बस. Thank you, Dr. Khidr. So please get it along with you, sir. Thank you very much and thank you for co-chairing over the session, sir. Dr. CL Double. Ro Khidr up, zara. Dr. Shogul. I always love to see him always, and this is a very beautiful comment and very wise and to the point. Sir. My pleasure. PC Rama. I request Dr. Kudar, please come forward. And let's have a group photograph. नहीं बहुत कुछ है दिल से देव दे रहे हैं और आपने हाथ लगाया जो दिल से दे रहे हैं बहुत कुछ है मैं तो लास्ट में हूँ थैंक यू वेरी मच Do we have a photographer here? So, thank you, Chairpersons. Now it's time for Dr. Prem Ratan Degawat. And now the session is Understanding LDL-C Variability, a Key to Better Cardiovascular Outcomes. And for the session, and we have Dr. Alok Mathur for chairing the session. Dr. Alok Mathur, sir, please. In the women power, we have Dr. Uma Kalia, one of very senior physician here in the town, and Dr. Ishu Goyal. She is a neurophysician from Fortis Hospital. She is a neurophysician, and we have Dr. Ravi Jain. A brief word about lipids. The lipids are always killing. And especially if you see the Indian scenario, South Asian population, 33% probably been at risk with this chronic heart disease. And basically we have a bad lipids. We have a low HDL, high TG, and now recently it's been done that the LPAs and ApoB are to be always at risk. So we love to have Dr. Prem Ratan Degawat so kindly highlights the understanding LDL-C, variability and key to better cardiovascular outcomes. And I request Dr. Ishu Goyal. So please
Good evening, everyone. First of all, I would like to thank Dr. Pratan for inviting me to the stage and sharing the stage with so many senior physicians and so many senior physicians sitting in the audience as well. So Dr. Prem Ratan Degawat is a senior interventional cardiologist and director of mitral and tricuspid valve therapy and associate director of TAVR in structural heart disease program. He holds MBBS, MD medicine and DM cardiology from KGMC Lucknow with advanced structural heart intervention and complex coronary fellowship from Italy. He is amongst the few specialists in India trained in advanced procedures like TAVI, TAVR, mitra clip, tri-clip and other structural heart interventions. He has extensive experience with 600 plus TAVI cases and research exposure across 2000 plus TAVI cases in Europe. His expertise includes TAVI, complex angioplasty, valve replacements, heart repair procedures, and advanced cardiac support systems. So it's my great pleasure to hear from him, and I am looking forward to a very knowledgeable session. Over to you.
Thank you. So I'm thankful to all of you just you came to us. And I'm again coming to my topic, that is the Inclisiran. And my topic is does the variability of the LDL can predict the bad outcome or worst outcome in the coronary heart disease? So my topic is the understanding LDL variability and key to better understanding of the cardiovascular outcome. And these are my disclaimer. This is my agenda. That first we'll discuss about the LDL cholesterol variability, then the complication related to this variability, then the importance of sustained LDL cholesterol reduction, then the challenges with the therapies, and the game changer reducing LDL cholesterol variability. So first we'll discuss about the LDL cholesterol variability. So this, you can see the upper left flow chart that LDL variability refers to long-term fluctuation or visit-to-visit change in the fasting LDL cholesterol level. Means that a patient came to your OPD and every time the LDL cholesterol has the variable, means sometime it is low, sometime it is high. It is not sustained and controlled, which is indirectly and directly associated with the coronary atheroma progression and can predict the future cardiovascular outcome. So for the measurement of the LDL variability, we have the 4 measurement, like we can measure the standard deviation of LDL cholesterol level. We can check the average successive variability. We can check the coefficient of variation. And we can also check by the variability independent of the mean, that is we call VIM. And what are the complications related to LDL variability? So if the patient has the LDL variability from the target, there will be higher chances of worst cardiovascular outcome, 18% higher cardiovascular disease, and around 30 to 40% increase in the myocardial infarction, and all-cause mortality, that is 19% increases. And these complications related to variability can, overall there is increase, 34% increase in the major adverse cardiovascular outcome compared to the non-MACE cases. So means that LDL variability directly affect the cardiovascular outcome. And this you can see that what is the hypothesis behind this LDL variability predict the worst outcome. It says that the variability in the LDL cholesterol level impair the atheroma protection by the LDL cholesterol, because the oxidized cholesterol in the endothelium can lead to the plaque rupture or plaque vulnerability that ultimately lead to the cardiovascular worst outcome. And what is the importance of the sustained LDL cholesterol reduction? So you can see that LDL cholesterol reduction cut the major cardiovascular event by 22% per 1 millimole of liter reduction in the LDL cholesterol level. That is 24% reduction in major coronary events, 25% reduction in coronary revascularization, and 16% reduction in stroke. That is if the LDL cholesterol level is maintained throughout the course. And this is you can see this chart that LDL cholesterol reduction lead to better cardiovascular outcome. The blue one is the upward trend, and the downward trend, and the red one is the upward trend. And this hypothesis has been studied in the sweetheart study. The sweetheart study, there was 4 type of scenario. You can see this diagram, that scenario first, the patient doesn't reach the target level at any point of time. You can see this blue one, upper one, that the LDL cholesterol doesn't reach the target level, and even at the 1 year, the LDL cholesterol is not reached at the level. Scenario 2 is that patient reached the target at 2 months. So you can see this red one, that within a 2 month, patient reached the target, but after the 2 month, there was no sustained LDL reduction up to 1 year. Scenario 3 is that patient doesn't reach target within a 2 months, but reaches the target over the 1 year. And the scenario 4 is that patient reaches the green one. You can see that the green one, the patient reaches the target at 2 months and sustained for a period of 1 year. So there are 4 scenarios in this sweetheart study, and this study shows that those with a scenario 4 who reach the LDL cholesterol level within 2 months and sustained for 1 year have 24% risk reduction in the mass and 15% reduction in all-cause mortality and 31% in myocardial infarction. So this trial, this studies has shown us that if the LDL variability is reduced and the target LDL cholesterol level is maintained, there could be a major favorable cardiovascular outcome. So what are the challenges with the existing therapy? That most of the time the LDL reduction not achieved because of the non-adherence to treatment. The most often time the side effect is 60% cause that the patient non-adherence. There may be refill changes, multiple time OPD visit, sometime patient take to forget. So these are the key factor that's the LDL level is not maintained. And this is the quintile diagram chart that shows that those patients who are non-adherence has the highest visit-to-visit LDL cholesterol level. Means that those patients who are coming repeatedly for the LDL level medicine, LDL level OPD visit have the highest variability in the LDL cholesterol level. That indirectly give us an idea that we should have the maintain the LDL cholesterol by different medicine or something by different drugs. For those that patient doesn't have to come repeatedly to the OPD visits. So this is the challenges. You can see that the pill burden, if the patient take everyday statin therapy, there are 365 pills. If you take the evolocumab, there will be 20, 24, 25 injections. But if he takes the Inclisiran, the dose is 2. And sometime the vaccination is coming, then only 2 vaccination. Sometime in the future, gene editing will be there, there's no medication. So that high annual medication required can result in a poor adherence, so that minimum medication can predict LDL cholesterol level variability very less. And this is the guideline that LDL cholesterol, the 2023 ESC guideline that standard target less than 55, and the reduction should be more than 50% in ACS patient, and in very high risk the LDL target should be less than 40. And this is the Inclisiran, which we have discussed about that. And it is the good thing about this Inclisiran is that there is a sustained reduction in the LDL cholesterol level, around 70% from the baseline. And you can see in the Orion 8 trial that LDL cholesterol was sustained, maintained up to 2 years with the Inclisiran. And the minimum 2 doses, one first dose, initial second dose is third month, then third dose is 6 months, and every 6 months. So this is the protocol, and this is that how these it significantly reduced the LDL cholesterol level around 70% reduction, and it is very safe compared to all other drug. In Orion 8 and Orion 9, 10, 11, the adverse events are less than 6% in Orion 8 and 8.2% in all other trial. And these are the key takeaways that it reduced the LDL sustainedly for 1 or 2 years, and it is well tolerated, safe, and it creates a high treatment adherence. So that's all from my side. Thank you.
Now we have a very important session, the main session going to be started, but I feel we have to be a very senior faculty with us, Dr. Dinesh Swarup Mathur, and I request Dr. Dinesh Swarup Mathur to kindly come over here and to chair the session, sir. Because the session will be from Dr. Samin Sharma, then it's Dr. Samin Sharma, Dr. Dinesh Swarup Mathur. Kindly escort. And Dr. Keshwari Boss, very smiling face, always, and whenever in need, and I look always for his guidance and all. So, because we have a very important session, and we have to be. मैडम काली कहाँ जा रही हो? अच्छा, मैडम is always taking notes. इनसे मेरे को बहुत डर लगता है कि कोई गलती ना हो जाए. So, Dr. Keshwari was most welcome. And now we are going to have the main session. And for the session, I'll request to the organizers to over to you, ma'am.
Thank you so much, sir. So I would like to request Mr. Nitesh Tiwari, Unit Head, Eternal Hospital Sanganer, and our Growth and Development Head, to please introduce the next session.
So good evening, ladies and gentlemen. It's my great privilege to introduce a true global leader in international cardiology, Dr. Samin K. Sharma. So Dr. Sharma serves as the Director of Cardiovascular Clinical Institute and Senior Vice President for Operational and Quality at Mount Sinai Hospital, New York, USA. And he is also the Chairman of Eternal Hospital. With an exceptional clinical career, he performed over 2,000 complex coronary intervention annually, achieving a success rate exceeding 99%, placing him among the very best globally. He is a pioneer in advanced minimally invasive cardiac therapy, including TAVR, mitral clip, and widely recognized as the master of rotablator. He has made landmark. We can give big round of applause for him. He has made landmark contribution in the field of including the development of kissing stent technique, which has significantly advanced the management of complex coronary lesion. Dr. Sharma is deeply committed to global medical education, leading renowned academic platforms such as complex cardiovascular catheterization therapies and cardiac care conference CCC live cases, reaching cardiologists across more than 170 countries. An alumnus of SMS Medical College, he is also the founder of Eternal Hospital Jaipur, reflecting his continued commitment to advancing healthcare in India. Unfortunately, due to prior commitments, Dr. Sharma couldn't join us in person today. However, he has graciously shared a recorded message for all of us. Ladies and gentlemen, please join me welcoming Dr. Samin K. Sharma, sir, as we now play his recorded video. Thank you.
All right, good evening to all the participants and the faculty for this evening program about updates from Eternal Hospital, and I'll be talking about some insight on the latest advances in interventional cardiology in 2025. I'm sorry that I could not be there because of some other prior commitment, but I'm making this recorded video for 20 minutes to show basically that where we are in terms of the recent advances that have taken place and how our practice has changed. So basically, as you know, this our interventional cardiology basically started by Andreas Gudrick, who is the father of angioplasty, and he's the one basically made intervention so successful, and that's where we are now. After so many years, we have become very low complication, basic complication, appropriately, that's those who needs it, and ambulatory means outpatient. So we did make this, although the video, the audio is not audible at present, but this is the AI generated, this Andreas Gudrick, which you call father of ambulatory. So basically what we are going to do is just show you some data. One is the mechanical circulatory support. What does it mean? So basically when patients have a weak heart, we have three devices which are used at present, and these are here. Balloon pump, Impala, and called ECMO. These all are used, and question is what are the data for them, whether it's successful or not. So first one is basically the data which we have seen for the cardiac shock is ECLS shock. That is ECMO using the cardiac shock patient, and they found up to 1 year no different whether used in the cardiac shock ECMO or no ECMO. And you see there is no different benefit or other minor benefits also. So all the small trial of 210 patients, but this is the third trial of ECMO which was negative for the cardiac shock patient. Then another device which we use is called Impala, or called microaxial flow pump, liquid danger shock. Same, the STEMI patients who had cardiac shock, you see we had Impala or standard care, many of them got a balloon pump, and this is the first time we saw that trial was positive in the sense that they received Impala, the mortality decreased by 13%. Big. And this is on top of it, because the device size is 14 French, usually when we do the stenting, it is about 6 French, when you put a balloon pump, it's 8 French, but Impala is 14 French, and therefore higher vascular complication. And see that despite that, the trial was positive, and therefore we have at least one device which showed positive in cardiac shock. There's another trial called early IBP in heart failure, L shock using balloon pump, and basically showed again no difference in the outcome, rather more bleeding and vascular complication. So this basically puts it together. These are the guidelines that microaxial intravascular flow pump, which is Impala, is 2A indication, but both balloon pump and ECMO are class 3 with no benefit. The second trial is that immediate versus stage pump or complete revascularization MI trial. As you remember, the patients who are STEMI and have multivessel disease, multiple trials have shown that opening all the vessels, not only the culprit which caused the MI, but all the vessels is better compared to just opening the culprit vessel. Then second question came that when do you open same hospital admission or you do it a stage after 4 to 6 weeks? And the trial basically has shown, one of them, the example BioVask, that if you wait or stage them, they start having more MI and unplanned revascularization because these patients are very acute. Their culprit lesion is very significant, but others also high pro-thrombotic milieu when they come back with the event. So therefore, the decision was made, or recommendation was, that multivessel PCI should be done at the same time or same hospital admission. Now we went to the next level, which is the option STEMI. So should you do all the blockage at the time 0 when you are doing the STEMI PCI, or you should do few days later, but same hospital admission few days later. Basically we found height of the red bar, the immediate complete versus stage complete, the immediate complete was not beneficial, and particularly some patients who are in heart failure, elderly, multivessel disease, they actually did worse with immediate complete. So what we learned, the best approach is multivessel disease, you do a culprit vessel PCI on time 0 when patient present, and then 1 or 2 days later, not at the same time, 1 or 2 days later, do the PCI of the remaining vessel and don't discharge the patient with the tight lesion when they come back with MI. Then the drug-coated balloon. So drug-coated balloon actually being used in India for many years, for 15 years and so, now for about 2-3 years, or 2 years actually, we are using DCB in our coronary disease. So DCB basically is a proprietary system. Basically the drug is mounted with the expedient, basically carrier you can say. The drug is on the balloon and it slowly releases once you inflate. And with the mechanism, it is staged in the vessel wall. So that's where the drug-coated balloon. So it can be used for both instant restenosis or for the native vessel. And why the drug does not wash out, or I would say that that is a whole science. And they're seeing about 20% of the drug stage, and that's what you need, 20 to 40% in the vessel wall, and that has been effective. So could be used for ISR, where the data are very strong. And then what about the native vessel? And they're going to share with you that where will be the native vessel. All types of drug, and biggest advantage is that it's a short DAPT and no worry about the side branches. So if high bleeding patients, you don't want to give long-term DAPT therapy, so you can use a drug-coated balloon. And so one trial for the ISR, which is the agent DCB versus balloon angioplasty, showed that agent DCB decreased the event rate by 30 to 50%, and there were no stent thrombosis because there was no stent. Overall, very positive, then led to the approval. But still, because the many other trials have shown, when you have ISR, the VDES is better. So these are the guidelines. The both drug-coated balloon and DES. VDES is recommended, but DES is low. I would say has an edge over the drug-coated balloons, but we still use quite a bit of DCB in ISR of the DES. So now this was the patient with ISR. Now, what about the native vessel? This is a trial from China called REC Case 1, and basically showed DCB in the blue and red in the regular DES group, compare DCB versus DES, which is what we use another stent, and basically showed that in native vessel, while we had a very effective in the instant restenosis, but the native vessel, drug-coated balloon was not good. You can even say they were bad. Many of these, there is almost a trend towards higher mortality. But what they show also within there, that if you have a small vessel, both DCB and DES are okay. But if you have a large vessel, event rate is 2.5 and 3 times higher with the DCB. So clearly the large vessel, no good for DCB. The small vessels are okay for DS if you need to use it. Then the branch. There are some many trials have been done that for the bifurcation, the side branch, do you just do a balloon or you do a DCB? And actually data has shown that DCB has a lower event rate, lower subsequent outcome. So therefore branch point, the small vessel and ISR are the one. So how do you take care of the coronary disease right now? The whole full circle going back to the balloon angioplasty era, that we dilate the lesion first and then we optimize, open it, plaque modification we call, by atherectomy, and then assess that it's nicely open. If acceptable results, then you use a drug-coated balloon. And if not acceptable, then you put a stent. And what are the groups where DS is better? DS instant restenosis, a small vessel, side branch, and high bleeding risk patients. So this is how we do at present. Then the imaging trial. What the imaging is, that we can do, in addition to the angiogram, we can do either IRS, this is called OCT, and this is called VS. Tells you exactly where the lipid is. So these are the three additional techniques besides angiogram, which we routinely use in many trials. And we have the criteria for them. And all the segments of the coronary tree have been evaluated by using this intracoronary imaging or even intravascular imaging versus angiogram. And all have shown positive results, majority of, I would say, 95% or so. There's one of the example is the OCT trial, which is OCT versus angio-guided PCI, and OCT associated with height of the blue bar compared to red is lower event rate. So this is a meta-analysis of all the randomized trials in this field, and basically show that whether you have a death, MI, TLR, stent thrombosis, all-cause death, that the imaging decreases the event anywhere from 29 to 50%. So imaging should become class 1 indication, and that is what is the most important, the post-procedure. And now the guidelines have emphasized that in complex cases, like left main, long lesion, bifurcation, total occlusion, the imaging helps it, so should be done routinely. Then the plaque modification intravascular imaging trials. So we have various devices. Use rotational atherectomy, IVL called shockwave, the laser, orbital atherectomy, cutting balloon, all have been studied. This is a study called roller coaster EPIC 22, where they compare all three devices. Devices were effective, lowest complication occurs with the IVL, but comparatively the laser did not do as good as rotational atherectomy or IVL. So therefore, what would come out to be in the calcific lesion, laser is inferior, but IVL and rotational atherectomy are equivalent. Another trial, the same message, that the rotational atherectomy and IVL are equal in terms of the performance in the calcific lesion. Then we did a trial called Eclipse, where we compare orbital atherectomy with another type of atherectomy device like rotational, but little different mechanism, against conventional angioplasty, and basically found no difference in outcomes at 12 months. So this is the first time the long-term outcome of a large trial of 1,800 patients, and there is no difference of atherectomy versus no atherectomy. Rather, the atherectomy patient has a little higher complication of slow flow and perforation, and therefore the whole idea that orbital atherectomy is better for calcific lesion kind of dissipated. What also we found that if you imaging guided PCI, whether you use orbital or not, it's decrease the event rate by almost half, from 12% to 7%. So therefore imaging becomes important. Then there is one trial which I put into this slide, that if you have a bypass surgery and now you come back with a blockage, should you go with a bypass artery or should you go with your own artery, native vessel? And this was the Proctor trial, basically assigned to PCI of the native vessel or assigned to PCI of the vein graft, and basically showed that PCI of the native vessel was more complication compared to PCI of the vein graft. So therefore, this is what we are practicing. Many people were going with the native vessel, but we always have gone to the vein graft. So vein graft PCI is better than native vessel PCI as shown here. Then the DAPT de-escalation. So what happened is, now our stents are very good. So we had trouble maybe in 1 month with rare cases. So we don't have to give the dual antiplatelet therapy for a long time. Now, the whole question was that can you take away that aspirin within a month or so? So there are two trials, actually there are three, but I'm showing two. The target first trial, patient with a low ischemic acute MI, patient with STEMI, but low ischemic risk were randomized to 1 month of aspirin Plavix versus, actually not Plavix, other agents are ticagrelor, prasugrel, or clopidogrel. So that's why the DAPT agent. So 1 month, and then after 1 month, aspirin was withdrawn and continued for 12 months. Second group, they got aspirin plus any of the agents that patient required. And what they basically found? Two things. That by taking aspirin, you did not have any issue with the ischemic complication. That's what we always worry. You take away the aspirin, what about period of stent thrombosis, MI? Answer is no. Second, the bleeding is significantly reduced from 5.6 to 2.6. So bleeding goes down without any effect on the ischemic endpoint as seen here. Then the second trial was a mere mindset. Little confusing in the sense that this is also a trial where all patients with acute coronary syndrome, not the low risk which I showed in the previous trial. All patients with acute coronary syndrome, they want to do the same thing. But what if you stop the aspirin after 1 month and then continue dual antiplatelet therapy for 12 months? And many patients have STEMI, non-STEMI, and unstable angina. What they found is very different, that you see a monotherapy versus that actually had associated with slightly better outcome. As you can see here, height of the blue bar, although did not make a statistical significance, but it shows that every patient of acute coronary syndrome, you cannot take away the aspirin. Maybe some cases are very complex. You need to continue. But simple cases, low STEMI, you can take away the aspirin. Then colchicine acute MI. We did many trials of colchicine, Colcode, the Lodoco 2, and multi-analysis showing that the colchicine was better in patients with acute coronary syndrome. This is a 2A recommendation by European Society. It works basically by working on the microtubules, prevent the regeneration of the microtubule, and that's how it's effective. And therefore, we have a trial called Clear Synergy, in which patients with acute MI, after 72 hours, they were given colchicine or placebo, and of course, there was another part was spironolactone, but colchicine, and basically found that by giving colchicine, we have a lower inflammation, which we already knew, but more importantly, outcomes were identical, no difference in outcomes. Just now, all of a sudden, the colchicine fails. So this always happens in our field. Everything we do good, and one day then trouble occurs and it's a negative trial. Then the FFR trial. FFR is kind of gold standard now. So unless it's a 90-95% support lesion, you decide whether the patient should get a PCI by checking the FFR. The number comes out to be by giving IV administration, either less than 0.8 or more than 0.8. The studies have shown that if it is less than 0.8, should get the stent. More than 0.8 can be followed medically. So phase 3 trial was a trial comparing FFR guided PCI versus bypass surgery, and basically showed that 3 years outcome was still better with a cabbage compared to PCI, but once you go to 5 years, the advantage disappears, except the peak revascularization is still higher in the PCI group, which we knew, but more importantly, no difference in death. There was slightly also higher myocardial infarction, but there was little, stroke rate a little higher with the cabbage group, but overall it showed that no effect on mortality and the hard endpoint, but higher revascularization occurred, which we always see with the PCI versus cabbage. Then it also showed that if your complex lesions, which you call based on the syntax, low risk, intermediate, and high, the cabbage is superior in patients with the high risk, and low risk could get PCI only. Then always question comes, patient got PCI, and now 18 months or 12 months have passed by. You got aspirin Plavix for 12 months, now you do what? You stop aspirin, you stop Plavix, or continue both of them. We actually have 2 trials now, which have looked into it, that after your time of given for about a month, 1 year, 12 to 18 months, many of them, the 5,500 patients were randomly assigned. After they completed their work, some people do 6 months, some people do 18 months. So after they completed the recommended DAPT duration, they were randomized to either aspirin alone or Plavix alone. And this is basically aspirin alone and Plavix alone and followed. And basically what we found, that overall endpoints were lower in the Plavix group, lower myocardial infarction, lower deaths from any cause, and stroke, and at the same time, there was no difference in bleeding. So what does that mean? That patients, after completion of their initial antiplatelet therapy, you should stop aspirin, not the Plavix. Many people stop Plavix. No. What we learned now is that stop the aspirin, continue Plavix, clopidogrel, that's what has been shown. And there was a smart choice trial also showing the same benefit. And also, what happens is the clopidogrel has a lot of protection for the stomach point of view, aspirin for double GI bleed, so and symptoms, so that clopidogrel on long run does much better. So last trial, which I want to complete these advances of 2025, is antiplatelet therapy with oral anticoagulation post DES. There are two trials. The question comes is that what to do. We know what to do during 1 year. That we continue oral anticoagulation with single antiplatelet therapy. But what do you do after 1 year? Nobody knows. There was no recommendation from any society. So what the two trials which came out, that if you completed your 1 year of anticoagulation with single antiplatelet therapy with the NOAC or DOAC, basically that patients receive those agents. So do you continue single antiplatelet therapy or just stop it? And that basically was that you, after some time, after that 1 year, NOAC alone or NOAC plus antiplatelet therapy of clopidogrel. And these were the patients, and what basically we found, that of course lower overall event, largely lower bleeding and no difference in MACE. What does that mean? That by stopping the antiplatelet therapy, which is like that was not my practice. I always used to continue after 1 year from change clopidogrel to aspirin along with the NOAC. But what we learn now from many data, that it is better to stop it. Why? Because NOAC alone has some antiplatelet therapy. And of course, we have lower bleeding, and these are the various outcomes shown there. But more importantly, even turn towards lower infarction, lower death, and of course, the composite endpoints, and significantly lower bleeding. So therefore, it is very clear that after 1 year, patients who need NOAC and they are taking antiplatelet therapy, we should stop the antiplatelet therapy. So we don't worry about the one trial. Then there's the second trial, the aquatic trial, same message. Aspirin in patients with chronic coronary syndrome, means stable CAD, NOAC alone or NOAC plus single antiplatelet therapy. As you can see, this time it's aspirin. Earlier trial was clopidogrel. This was aspirin. These are the high-risk patients, high residual atherothrombotic patients, high creatinine, there are multiple DES for acute coronary syndrome, diabetic, multivessel disease complications, and so. And what basically found the same message, that oral anticoagulation alone have a lower event rate, which is the red bar, compared to the blue bar, which is oral anticoagulation plus aspirin. So, and of course, there is a higher bleeding if you continue anticoagulation plus aspirin. So, message became very clear by two trials that by stopping the antiplatelet therapy with NOAC, there is no harm in acute events or ischemic events. Rather, it will be associated with a lower bleeding rate and seen, and even almost lower mortality in some of the trials. So therefore, standard practice should be that after 1 month, 1 year of NOAC plus antiplatelet, where you should stop the antiplatelet therapy. So these are the top new advances of the last year, and I want to put it together in simple way. Because sometimes it may be a little too much for some of our attendees. So I want to just talk about what message I wanted to convey. What we learned. What we learned basically in 2025 trial, ECMO and balloon pump in cardiac shock, DCB in large native vessel, colchicine in acute MI did not work. It should not be used. Second, FFR guided PCI in multivessel STEMI, P2Y12 monotherapy, orbital atherectomy laser in calcific lesion. 1 thumbs up. So usually they did not go, they were not positive. Then FFR guided PCI versus cabbage at 5 years. The stage was immediate, complete revascularization in multivessel STEMI, and aspirin withdrawal in low-risk patient is all right. You can do it. Then Intel and cardiac shock, the ideal and rotational therapy in calcific lesion, and clopidogrel monotherapy compared to aspirin, long-term PCI, and vein graft PCI over native vessel I would say 2 thumbs up. But largely, the DCB in ISR and side branch, the imaging, guided PCI, and lastly, NOAC or OAC alone, and no antiplatelet therapy, long-term post-DS PCI with 3 thumbs up. So 1, 2, and 3 are a recommendation, 1 thumbs and 2 thumbs and 3 thumbs to become the better interventionist and improve survival. And that is what happened. Increase in power use, decrease orbital restrictional alpha use, increase intravascular imaging, DCB, IVL, that will happen in Mount Sinai in 2025. And this is just to hold the old data, but that's the only one available. Mount Sinai remains number 1 in terms of the volume in the New York State, and lower complications by noted by 2 stars. 2 double star means your complication or your mortality. 30-day risk adjusted mortality is lower than statewide average, and that's what we received for last 24 years. And this year also there was a growth in intervention in every aspect, coronary intervention, endovascular and power cases, and the complications still remain the same, less than 1% which happens. These are the various structural devices which we use, tower, mitral clip, MTL, tricuspid clip, TMVR, balloon valvuloplasty, and so forth. I really take a pride of our success of CCC webcast. What it is, every month for coronary, 5 Tuesdays a month, 8 to 9, we do the live case after the e-blast, and then go over the case for 1 hour and discuss it. Everybody had a chance to talk about it, and this has been a phenomenal success. Then we added endovascular, then the structural, and you see here 30,000 per month in 176 countries. And India and United States are neck to neck in terms of the overall the participant numbers. So very, very successful. I take a pride in teaching. I always want to teach back from my even medical school. Of course, during them, used to teach the entire class and continue that. And now with this global teaching, which our outcomes, which we have very low, can be attributed, can be extended to anybody who can follow our thing. Lastly, the teaching now happens on your phone, not in the classroom setting, and we have multiple apps, cardiology apps, which for any disease process, and then we keep continuing, keep making it. There will be many more in the future, and that just to say that's how we go through all the disease processes, the techniques, and so to make our interventionists better. And this is like all your book on your intervention book on your iPhone, and then you can, or Android, and then you can use them during your complex procedure. And thank you very much, and good luck for the rest of the evening and your subsequent, hopefully good interaction, and you'll be able to take some key points from today's presentation into mind to take to your practice to become a better operator.
Wonderful. What a great. Dr. Samin is known for always innovative. He has always a new ideas. And see, all the world, he's covering more than 176 countries and always having a 1 hour webcast and teaching all of the countries every month. And to the credit, the Mount Sinai stands the number 1 with the minimum complications, the highest successful procedures. There was a time that the PCI used to be taken as a very difficult note, but today the things have changed. If you take all over the global prevalence, there are 321 million patients are in a coronary heart disease. And you will be surprised that 10 millions are dying annually because of lack of the approach, a lack of the awareness or the competence. So many of the reasons. And if you see the projected, out of 321, down the line 2050, we'll see that the 32 million deaths will be there annually. But I believe the data may be wrong proof, because we have such eminent cardiologists who are doing excellent procedures, who are doing excellent jobs, and especially the South Asian population, we see that the 60% of the coronary deaths are from South Asian country, primarily from India, Pakistan, and Bangladesh. But the things will be reversing shortly now. So it's a time to honor our chairpersons, and I request Dr. Prem Ratan Degawat to please kindly come over here to deliver a small memento from the organizers to honor our chairperson who have taken a very precious time to come over here. And I request Dr. Uma kindly be over here as a chairperson, because the chair is always finding empty over here. So we have a Dr. Ravijan, who's a very senior and always have master stroke, always all the fields. Dr. Boss, पहले हमारे गुरुजी को दें. Dr. Dinesh Faruji Mathur is a teacher, and he started rheumatoid practice in the state of Rajasthan. He is a father of rheumatoid here in Rajasthan. Dr. Ishu Goyal, she is a neurophysician from Fortis Hospital and a very senior neurophysician, and she has taken a lot of credits to her work. Thank you, ma'am. Thank you for coming and sharing. Dr. Prakash Keshwani, he Chupe Rustam. Every month he is doing a thyroid update and always attended at a very high on the Zoom link. And on tomorrow and the Sunday also tomorrow you are got a 2:30 another thyroid update on the Zoom, which probably I believe.
And you are the lifeline of that because until unless you don't ask the questions, the program goes in a bad.
But let me tell you, friends, all over India, Rajasthan doing the highest in thyroid update and diabetes update. Dr. Ravi Jain, sir, please, we'd love to have you. Thank you very much. Boss ने अभी 75वीं जन्मदिवस मनाया बड़े शानदार तरीके से लगते 75 ये नहीं है. Boss, most welcome, sir. Thank you, boss. Dr. Uma Kalia, she has been very sincerely and always taking the notes on. I always scared of her presence. Thank you, madam. I always appreciate your presence. Thank you, madam. And now time to honor you, sir, also. Boss के लिए. Boss को 2 बुके दो ना यार. एक पिछले सेशन का एक कमिंग सेशन के लिए. So thank you very much. Thank you to the co-chairperson. Now I'll be requesting for the next session, and I'll be honored. Dr. Jagdeep Dogra, a very smiling person, and I always love to see him. Dr. Sanjay Mandeta is a president, PHNS. He's a wonderful guy, always to the point, always smiling. Dr. Jain Sharma, he is a dean for Arya Medical College. We have a Dr. D.D. Deol also, for HOD from probably from SMS, then Mahatma Gandhi, then JNU and so many places. And we have a D.D. Gupta also, a very senior professor from Jaipur. So Dr. D.D. Gupta, please come over here to chair and co-chair over here for the next session. We have Dr. Degawat have been, sorry. Dr. Prashant Dwivedi, he will be talking on structural heart intervention SAD. What do you call it SAD? There was a time that they said structural heart disease from rheumatic heart disease. You will be surprised. All over the globe, rheumatic heart disease, India was 60% contributing for primarily from the rheumatic heart disease. But now the things are being changed because of the competence, such a nice, we have excellent cardiac physicians and interventionists. And early care has reduced rheumatic heart disease to a significant level, but we have now increasing level of structural heart disease. Over to you, sir.
Thank you, sir. Thank you. So in next few minutes, I am going to talk about the structural heart intervention. So I am going to switch the gear from pharmacotherapy, from coronary intervention to now the structural heart intervention. So we all know that in past 20 years has been a remarkable period of innovation in cardiology, and innovation is a continuous process. So structural heart intervention, we all know about the congenital heart intervention, ASD, VSD, PDA, closure, RSOB, balloon aortic valvoplasty, balloon mitral valvoplasty, and balloon pulmonary valvotomy. So advanced structural heart interventions include transcatheter aortic valve replacement, mitral valve replacement, pulmonary valve replacement, tricuspid valve replacement, transcatheter edge-to-edge repair, that is a mitral clip, MiClip for the severe mitral regurgitation, and certain other newer therapy. And there are certain other structural heart intervention which includes left atrial appendage device closure, L-core septal ablation, and the paravalvular leak closure. So I am going to start with the aortic stenosis. So severe aortic stenosis, if you look at the severe aortic stenosis, the prognosis of the severe aortic stenosis, if you compared from most of the metastatic cancer, the aortic stenosis has a worst prognosis. So the 5-year survival rate is just 3% in a severe inoperable aortic stenosis, while the prostate cancer and ovarian cancer is having a better prognosis compared to the severe inoperable aortic stenosis. So I'm going to start with a case of aortic stenosis, 75-year male, came to emergency, blood pressure of 70 systolic, cardiac shock, acute decompensated heart failure, and on ventilator, on vasopressor. Echo, critical aortic stenosis, ejection fraction 20% only. Creatinine 2.1, echo, critical aortic stenosis, 24 hours in ICU, conscious, alert, but still on ventilator, blood pressure 170 on high dose vasopressor. After 5 days in ICU, conscious, alert, but still unable to be in the inotropic support for last 5 days. Now question comes, what next to be done to bring this patient out of ICU? So being a critical aortic stenosis, it's a mechanical problem. So patient will not survive until aortic valve open. So surgical consultation done for surgical AVR due to advanced age, low ejection fraction, cardiac shock, very high risk for surgery and denied for surgery. Then question come, what to do next? So what if this patient of severe aortic stenosis doesn't replace valve timely? So most of the patient, almost 50% of the patient doesn't survive more than 2 years. So 5-year survival is just a 20% if these patients are being managed medically, and out of 4, a 2 patient, almost 50% patient dies in 2 years. So if we treat these patients at timely, the natural history of these patients may change. So the dream come to reality on April 16, 2002, when first in man transcatheter aortic valve replacement was done by Allen Crever in 2002. It was severely in critical aortic stenosis, inoperable. Surgeons have denied. Patient has a low ejection fraction, and nobody wanted to touch that patient. And that patient underwent transcatheter aortic valve replacement and then survived. So this is a timeline of innovation from 1958 to 2007. Then in 2002, the first transcatheter heart valve replacement was done. Then back to our patient. What we did for that patient who came in cardiac shock on ventilator for 5 days, not able to wean off from the inotropes and not able to bring the patient out of ICU. So her team consulted, we decided to do a rescue transcatheter aortic valve replacement, family counsel, agreed for the procedure, cardiac CT done, analyzed, this was the CT scan, we did the aortogram, and we crossed the wall, we did the balloon aortic valvoplasty, open it with the balloon, and then we replaced the wall, we position it, and then we replace it. Post hour, within next 6 hours, patient becomes off vasopressor. In 24 hours, extubated. In 48 hours, EF improved from 20% to 40%. And on day 3, patient shifted to room. On day 4, discharged to home. And on completed 5 years follow-up. So until few years back, these patients used to die without any intervention or surgery. But in last 15 years, the biggest innovation in cardiology is the transcatheter valve replacement. So there are now very much evidences there. So it was started with a prohibitive risk patient, then it came to for high risk patient also. Then the transcatheter therapy started for the intermediate risk patient, and now for last few years it has started for the low risk patient also. So there is enough evidence to support the transcatheter aortic valve replacement compared to the surgical group patient. So now question comes, can we do it in a tricuspid aortic valve? So we have all know that the transcatheter aortic valve replacement can be done in a native tricuspid aortic valve. Then what about the bicuspid aortic valves? Can it be done? Answer is yes. So this is another patient, 75-year female, bicuspid severe aortic stenosis, underwent transcatheter aortic valve replacement and doing perfectly fine. So what about the patient? There are many patients who already underwent a surgery. A patient already had a prior surgical aortic valve replacement. What is the fate of these patients? So after 10 to 12 years, because these surgical patients, surgical AVR patients, these are the bioprosthetic valve. So these aortic valve, surgical aortic valve replacement tends to be degenerate in 10 to 12 years. So many times we do the transcatheter aortic valve replacement in a prior surgical aortic valve replacement. So it's a valve-in-valve situation. So this is a patient with a 80-year male, diabetic, hypertension, hyperlipidemia, prior surgical aortic valve replacement, and presented with a recurrent heart failure symptoms. Then patient underwent a transcatheter aortic valve replacement in a prior surgical aortic valve. So you can see these dots, which you can see. This is a prior surgical aortic valve frame, and within that we are replacing another new transcatheter aortic valve. So what about the severe aortic regurgitation? Is not a class 1 indication, but has to be done only in a patient which is surgically denied. So this is a patient, 75-year female, with underwent a transcatheter aortic valve replacement with under rapid pacing, and you can see the echo that there was a severe aortic regurgitation before and after procedure. There was no aortic regurgitation. Then what about the patient who had a prior mechanical mitral valve surgery and patient had a mitral valve replacement, and now aortic valve has now degenerated. Patient already underwent a one open heart surgery, and now the patient is high risk for a second open heart surgery. So in these patients also we can do a transcatheter aortic valve replacement. So this is what we have done it. So you can see this rim which is visible is the prior mechanical mitral valve, and now the aortic valve has been degenerated, and now we are positioning our new transcatheter aortic valve at the level of aortic position, and this is the prior mechanical mitral valve. So this was the final aortogram. So we have published the editorial also on the patient of a transcatheter aortic valve replacement in a patient with a prior mechanical mitral valve prosthesis, because in most of the trial, most of the studies, these patients were excluded from the trials, because these patients are predominantly of rheumatic heart disease, and they are found most of the time in the Southeast Asian region. So this is the magic of the transcatheter therapy. Within after 2 to 4 hours of therapy, you can find these patients lying in their on bed and reading their novel. So this is the benefit of the transcatheter aortic therapy. What about the mitral valve? We all know about the BMV, balloon mitral valvotomy, but what about the mitral regurgitation? Previously, there was nothing to do, but now there are many things which we can do is, so this is a patient with a degenerated bioprosthetic valve. So mitral valve which has a bioprosthetic valve which has been degenerated. Then what we did was we replaced another valve inside of that valve. It was done in just 1 hour, and then you can see this was before the procedure there was severe mitral regurgitation, and after the procedure there was no mitral regurgitation. Patient did fine. Then what about the TMVR ring? Many times surgeon fix the mitral valve repair by putting a ring. So in these patients also we can do the transcatheter mitral valve replacement. This is a patient of 75-year female with a severe mitral regurgitation, had a prior mitral valve ring, underwent valve in ring procedures. So the ring was there to stabilize the valve, and we put another valve inside of that ring. So this patient we did it 4 years back, and this was the first TMVR ring case in India. Then what about the mitral transcatheter H2H repair? Because sometimes these patients, not every patient is amenable for the valve replacement. So in these patients, sometimes we do the repair of the valve by bringing both the leaflet together and bringing down the mitral regurgitation from severe to trivial or a mild. So this is a case of 74-year female, severe mitral regurgitation, underwent mitral clip procedure, and after just one clip, you can see there was a severe mitral regurgitation before the procedure, and after the procedure was just a mild mitral regurgitation. What about the tricuspid valve? Tricuspid valve being considered as a forgotten valve, but now in 2026, this is not a forgotten valve. So there are many. This is a 73-year female post-mechanical DVR patient, underwent a tricuspid H2H repair. So there are many therapies are now available for the tricuspid valve also. It can be a repair, it can be replacement, it can be a transcatheter H2H repair, it can be a new valve replacement, it can be a spacer. So there are many valve therapies are available. So I am not going into detail of these therapy. So this is a case of prior tricuspid valve replacement by the surgeons, and now this valve has been degenerated, and so then we have put another transcatheter valve inside of that tricuspid valve. Then this is another patient. Sometimes the transcatheter, the therapy which is available is not, patients are not suitable for these patients. So there is another patient, 70-year female, had a severe tricuspid regurgitation. You can see this, the severe tricuspid regurgitation, and that patient was not suitable for other therapy. So what we did was we put a spacer inside the tricuspid valve, and then patient did symptomatically much better, and you can see this, there was significant severe tricuspid regurgitation, or almost torrential TR, and it has come down to almost mild tricuspid regurgitation. This was the first case in India and the entire Asia Pacific, and the 5th case in the world, which we did at Eternal Hospital. So patient completed 5-month follow-up, at present in NYHA class 1, then sometimes we cannot do anything over the wall. So in that cases, because the patient with a severe tricuspid regurgitation have a backflow which leads to the congestion over the liver, congestion of the pedal edema and liver cirrhosis and stomach congestion. So in these patients, sometimes to prevent the reflux, we put the two valve, one in the IVC and one in the SVC, to prevent the reflux of the tricuspid regurgitation into the upper body and the lower body, so that the patient becomes symptomatically better. So this is a case of trick valve in which we put the SVC and IVC valve. Sometimes we do the transcatheter pulmonary valve replacement also. These are the patients most of the time are patients which have a tetralogy of Fallot repair. So this is a 23-year male, known case of TOF, underwent TOF surgery in past and now presented with dyspnea on exertion, severe pulmonary regurgitation, cannot go for a recurrent surgery. So underwent a transcatheter pulmonary valve replacement, and patient is still doing fine. Sometimes there are surgeons repair the wall, replace the wall, and then there is a new leak around the wall. So what we can do is we can close that paravalvular leak by putting the devices just close to the prior valve. So this is a case of pulmonary embolism. So many times we encounter many patients with a pulmonary embolism, and the recently updated guideline has clearly recommended that the recent trial has also shown that the interventional therapy has shown a better outcome compared to only the pharmacotherapy, especially in these pulmonary embolism patients, because many times these patients are very sick, cardiac shock, not able, patient is gasping, almost 70% of saturation, 70-80% of saturation, and in these patients, this therapy does wonders, and patient within 1 or 2 hours, patient becomes symptomatically better, and these are the life-saving therapy. So we did the oldest patient tower in oldest patient in India, and that was the third oldest in the world. There are many patients coming from across India and out of India for heart valve intervention. There are sometimes the patient cannot come to us, then we travel to give this therapy across India and Southeast Asia. And this is the center of excellence, that Eternal Heart Valve program, by having a dedicated heart valve clinic, live cases and training workshop. And we believe in our mission by Dr. Samin Sharma, teach, treat and train, and we are working on it. Thank you.
For Dr. Prashant, it was really amazing, because I have seen a couple of the cases like a pulmonary embolism is such a life-threatening and such a severe pain in the chest. I can still have, because I've seen a couple of the patients, and beautifully what you're doing. I never thought that you are not only the state in Rajasthan, you are not national, rather you have a global presence. You're amazing, amazing. It's really very informative. And I can see father of Dr. Parmananji Bhargav over here. Sir, please आप आइएगा co-chair पे बैठिएगा sir. नहीं sir, please. ऐसा तो हो ही नहीं सकता. आपका जो स्थान है हमारे लिए बहुत विशेष है. You are most welcome, sir. Let me escort you, sir. And there's a special announcement. I request to the people coming over, the doctors, kindly do not leave the place. You can carry on your drinks and the food, but do not leave, because we have a couple of the prizes for later on, Women's Days last year, and then we have a cake cutting ceremony, and then we have a good photograph also. So I all request you to kindly don't leave the place. So Dr. Prem Ratan Degawat, sir. It has been already introduced, I believe. Who doesn't know you, sir? You have such an omnipotent place. Not in state, but rather in global position.
So, thank you. With the sake of time, I will close my session very early. So, my topic is the new frontier in the heart valve treatment. Most of the things has been covered by the Prashant, and I'm just giving a rough idea, very basic idea about, because you all are physicians, I know everything, you know about everything, but I still just want to give a basic idea that you can see your patients and can refer your patient. So this is a global burden. Global burden is increasing day by day, because because around the aging, the average age of the people is increasing day by day. Because in India now the average age of the people is around 72, before it was 62. So that's, as the age increases, the valvular heart disease problem increases. That is that in the future, the burden of these valvular disease will be going to be very high, and we have to go treat all these valvular heart disease without any surgical intervention. And people know that people don't want any surgical intervention. They want non-invasive, non-surgical treatment. So why the most important thing is that who are the candidate for these transcatheter treatment? So these are the indication. Means that every patient of aortic stenosis is not a candidate for transcatheter valve replacement. Who are the candidate? First is if a patient age is more than 65 years, he is the candidate for TAVI or any transcatheter treatment. Suppose if the age is less than 60 years, then it's a dilemma. If the patient really want, he can go for this transcatheter treatment. Otherwise, he is the candidate for the surgery. Then, if the age is less than 60, but he or she is very high risk for surgery, then it's a case that in case that he can go for the aortic valve replacement or transcatheter treatment. If the patient is inoperable, means that surgery can't be done, then and only we can have the transcatheter treatment. If there are associated severe kidney disease, renal disease, pulmonary valve diseases, then he is the candidate for transcatheter treatment. Non-case of cancers. And if the patient is the predictable survival is less than 10 years, then he is the candidate of transcatheter treatment. These are the only indication. Why these are the indication? Because the TAVI, the TMVR, they have the bioprosthetic tissue, means that these valves will degenerate within a 10 years. So that is the basic problem. If a patient's survival is more than 10 years, then we have to think again that yes, if a patient survives more than 10 years, maybe he is a candidate for metallic valve replacement. So that is the basic understanding about the transcatheter treatment. We have discussed about TAVI, aortic stenosis. I'm just giving a rough idea of how we diagnose it. The severe aortic stenosis is diagnosed when the aortic valve opening is less than 1 centimeter square and the velocity is more than 4 meters per second. Then this is the flow diagram that you can see that if the patient is asymptomatic, the prognosis is very good. But once the symptom like angina, syncope and failure occurs, the prognosis is very poor. Meaning that if the patient has the heart failure, he will die within 2 years. That is the very drastic prognosis of the aortic stenosis. And you can see the worst prognosis compared from the lung carcinoma. And that's why the 1958, the first surgical valve invented, till 91, till money surgical valve has been invented. There are two types of surgical valve, metallic and the tissue valve. The metallic we can say is mechanical. Tissue valve we know that they made of the pericardium of porcine and bovine. But around 30% cases of these aortic valve, surgical aortic valve patient cases are not fit for the surgery. That time what happens, that was the real evolution of the TAVI. What happens in 2002 in Europe, a case of severe aortic stenosis, but having the ejection fraction 12%, and 3 cardiac surgery team had denied for the surgery. So that was the basis that this patient was very young, 57 years, and the surgeon denied for the surgery because of the ejection fraction rate 12%, and patient was very high risk in inoperable type. So that time, this is the father of cardiology, we can say the Alan Crevier, who died recently in 2024, who did the first case of this patient, and this patient survived for the 15 years. That was the first case in 2002. It was published in the circulation. That has the milestone in the field of the transcatheter treatment. And the patient survived, and you can see after 15 minutes of the transcatheter surgery. And this is the paradigm shift that from 2020, most of the cases are being shifted from surgery to transcatheter treatment. And these are the landmark trials, that is partner 1, partner 2 and partner 3 trial, which have given an idea that in low risk, high risk and intermediate risk, the TAVI is be done, and it is equivalent to surgical aortic valve replacement. And these are the complication rates. You can see that complication rates are very low, stroke less than 2%. The only pacemaker rate is 5 to 15%. Now it has reduced to less than 5%. And compared to surgery, the risk of the transcatheter treatment is very low. And when we compare the long-term data, the data has come that 7-year they compare the surgery with the TAVI with the 7 year, that the TAVI is comparable to surgery. means that surgery can be replaced in the future with those who are the candidate for the surgery and TAVI also. And these are the basic steps which has been covered. I will not go into detail of that, how these. Just want to show this basic animation so that you can understand how this TAVI procedure is being done. That you can take a wire from the right or left humeral artery into LV cavity, and these are the crimped valve. And you can see within a 5 minutes, we can deploy these valve at aortic position. You can see that this is animation on the right side of video. You can see that the real time how these valves are being deployed. So such a easy procedure, within a 10 minutes, we can deploy the valve. So that is you can see right side of video that how easy to deploy. And the good thing is that valve function immediately after the replacement. And these are the TMVR. We have discussed, Dr. Prashant has discussed that we have done many valve in ring, valve in case, everything we have done, and not going in detail. TTVR, this is the transcatheter treatment of the tricuspid valve replacement. And this is the first case in Rajasthan we have done, the first case of transcatheter tricuspid valve replacement in valve cases. And you can see that there are two valves, aortic, mitral, and the last one was you can see in the left side of video that transcatheter, aortic, mitral, and this is the tricuspid valve. And this was and you can, if you can understand, there is a significant reduction in the end diastolic volume with this tricuspid valve replacement. And this was the first case in Rajasthan that we have done in the Eternal Hospital, and it was published in various newspapers. Other that we can replace the pulmonary valve, we can replace and the TR therapy that the edge-to-edge repair. What is this? Just giving a rough idea that when the mitral leaflets don't copt at the same level, then this clip can approximate these leaflets at the level of the mitral annulus, and we can have reduced the reduction of the mitral regurgitation. So how this works? That is the Al-Ferrier technique. Al-Ferrier was originally a surgeon who treat this mitral regurgitation was just stitching the regurgitant part. So how it works? These are the clips which can approximate these regurgitation, and these are the basic idea. And I'm just giving just a rough idea that the left side of video, you can see these clips. When these clips close at the level of the regurgitation, the most of the time mitral regurgitation improved. And you can see in the left and right side of video, this is the 3D view of the mitral leaflet, and the right side you can see the clip has been produced and reduced the mitral regurgitation. And this is the basic mechanism that we have adapted from the surgery. Without surgery, we can clip these mitral leaflets. And this is that how these clips are effective without surgery. Those patients who are not fit for surgery, those are not candidate for the surgery, have severe mitral regurgitation, denied by the surgeon, we can treat with the mitra clip or MyClip. These are in conclusion, that the transcatheter valve treatment is safe, effective treatment, alternative to surgical valve replacement. In those patients who are not fit for surgery, those who are not more than 65 years are the prime candidate for these transcatheter treatment. And nowadays, more and more patients are opting these type of transcatheter treatment, who in these type of treatment, we can discharge the patient on the next day if the patient want. So that is the beauty of these transcatheter treatment. And thanks all. Thanks you all. Thanks from myself. Thanks.
Sure, wonderful. It's a beautiful deliberation. Now we are coming to the fag end of the whole cardiac symposium, and I request to the organizers for the thanks message and vote of thanks, and rather same time I request for the cake over here. And at same time I request organizers to kindly honor our co-chairpersons, and I request Dr. V.D. Sharma also to kindly come over here on the stage. He is one of them, always methodically, academically strong by all means. So I request Speaker Dr. Parmanji Bhargav. Paramanand ji, Paramanand, जिनके presence से Paramanand आ जाए, Dr. Paramanand ji. I've seen his practice, what a very roaring practice, and he has crossed 94 years, sir. आप कुछ एक कोई मैसेज देना चाहेंगे एससीसी के लिए और प्रशांत जी के लिए और डॉक्टर प्रेम रतन के लिए? एनी मैसेज, बिकॉज द वे दे आर डूइंग एक्सीलेंट जॉब विदाउट ओपनिंग द चेस्ट.
That is the great thing they are doing. I have been looking on WhatsApp what Dr. Degawat is doing. I don't know much about cardiology, but he is doing commendable.
Thank you very much. I request Dr. Didi Boss. Dr. Didi Gupta, one of our senior physicians, is a senior to me, and I request for your presence. Kindly make. Thank you very much. Thank you for you coming. Dr. Jain Sharma, who is our Dean, Arya Medical College, is smiling always. I love to see him always, sir. Thank you. Thank you. I'm being honored for your coming over here. Dr. Sanjay Mehndiratta is the most active. He is the president of most active. He is running a metabolic club also. He's a very meticulous way. Thank you, sir. We are all honored to have you here, sir. Dr. Jagdeep Dogra, one of most senior physicians, and सारे seniors के patient ही आपके पास रहते थे, boss. Thank you, and he has been gifted by Dr. Lavdeep Dogra, who is a very renowned nephrologist. His sweetness, his presence, his acumen is always with the international. Thank you, sir. ऐसा एक good photo के लिए रुक जाए, sir. Dr. D.D. Dewal Bus, he has been HOD medicine. Thank you very much. And Dr. V.D. Sharma also, हमारे V.D. boss को भी दो भाई. Is always present. अरे he is meticulous. बहुत से फटाफट केक वेक मंगवा लो, एक ग्रुप फोटो करा दो, और जरा बाकी सब चेयरपर्सन को तृष्णा हो रही है, प्यासे हो रहे हैं, थर्स्टी हो रहे हैं. So, एक ग्रुप फोटो. केक वेक तो लाओ यार. फटाफट मंगवाओ यार. We have got a cramps in the stomach.
So good evening, everyone. On the behalf of Eternal Hospital, I extend heartfelt gratitude to all our esteemed speakers, delegates participating for making this symposium on New Horizon in Cardiology a great success. I would like to express a special thanks to Dr. Prashant Dwivedi, Dr. Prem Ratan Degawat sir, and Dr. Pradyuman Sharma from RSSDI. Give a big round of applause for them. API and Echocardiography Society of Jaipur for their valuable contribution, insights and support in enriching today's academic discussion. We are also deeply grateful to our collaborators of Heart and Valve Foundation and all organizing team members. Those efforts behind the scene made this event seamless. Lastly, thank you to our audience and pharma companies like Novartis, Eucardis, Torrent, Abbott. Thank you very much. Give a big round of applause for pharma companies. Well-known and well-run company. I request all marketing colleagues to join on stage for good photograph, and I request also Dr. Priyanka Man from Eternal Hospital Sanganer and also taking care of structure heart department.
Hello. Vikrant, Prashant, Bhavani, Sahil, Chetan, Prithvi, Uma Shankar, and Sagar. आप सभी लोग आइए.
महेश जी, अरे छुपे रुस्तम आओ यार.
राजदीप,
I need not to call your name. जो मुझे जानता है वो आ जाए.
डॉक्टर खटाना, डॉक्टर रूपम, डॉक्टर मेघराज, आइए आइए सर.
अरे इसके लिए स्पूस तो लाओ यार, उंगली से थोड़ा खिलाएंगे यार. अरे कितनी सारी नहीं, एक से थोड़ा सा हो गया यार. हाँ, we should have like a lot of spoons. Hotel people, anyone from the hotel, kindly get the spoons done over here. Hotel people, चलो बस केक काटो अब तो. अरे आप तो काटो यार.
ये कैप चला गया ना, 2 ऑफिस में भी आएगा कैप चल, 2 ऑफिस में आएगा. पहले बंद करो. ऑनलाइन जा रही है. हाँ. नहीं तो लाइव चलते ही रहो तो स्टॉप डायरेक्ट बंद कर दो. यार मारी हुआ पेंटर ने लगी सीधा कीजिए वहाँ दाल वाली. बंद कर दीजिए. ये मैं रिकॉर्डिंग नहीं कराई थे ये तो रिकॉर्डिंग ही ऑनलाइन पे जा रही हो गए. बंद कर दीजिए. ये तो यूट्यूब पे जा रही है ऑनलाइन रिकॉर्डिंग की जरूरत कर जा स्टॉप.